presented to the Charitable Funds Committee on the 13th of January 25. Key points are Audit Wales intend to issue an unqualified audit opinion, but they'll update the board shortly. The Charitable Funds Committee recommends to the board to approve, following that meeting, the annual accounts, annual report and the letter of representation. On the assumption that the board will approve the accounts, they will be provided to Audit Wales, who will then ask the Auditor General for Wales to sign the accounts, and then they will be filed with the Charity Commission by the deadline of the 31st of January 25. In terms of an overview of the accounts, income from donations, grants and legacies was £507,000 for the year. There was a small adjustment in the accounts actioned following a clarification of some deferred. In terms of income from charitable activities, that reduced during the year by £70,000, largely due to in 22-23 we had some significant funding for filming in St Cadoc's, and that fund has been utilised during the year. Investment income of £211,000 was received. That's an increase on the previous year, and expenditure has increased by £209,000 as well. And in the annual report, there's a description in quite a lot of detail about the areas we've invested spend, particularly around patient welfare, defibrillators, and support for cancer care and things like that. So this results in a net decrease in funds of £381,000, which is offset by a gain on investment assets of £375,000, so leaving an overall net funds reduction of £6,000. The charity holds £5.8 million worth of fixed assets at the end of the financial year and £641,000 in cash. I'd like to take the opportunity to thank the finance team and the charitable funds team for the preparation of the accounts, and what I think is, I would suggest, is a very good annual report and very informative annual report. So that's an overview of the accounts. Thank you.
Thank you. Has anybody any questions? As chair of the Charitable Trustee Fund, Paul, would you add anything?
I would just like to add really my thanks, I think, to Nicola, Rob, Mark and the team for their efforts, also to Rani and the team for the paperwork and the governance arrangement, to Julie Rees and Audit Wales for their support and the way they've handled the audit accounts and the relationship we've built up with Audit Wales, which I think has been exemplary, and to members of the committee. I mean, I think if you look at the annual report, it is detailed, it's thorough, it explains the funds, it explains how we're spending it. But I did want to take the opportunity of thanking all those who've donated to the charity. It is making a difference, not only to patients, but to staff and to local communities. And we greatly appreciate everyone's input. And I'm happy to support the recommendations as put forward by Rob and as the finance lead.
I think that on behalf of this organisation, I think that the Charitable Funds report shows the huge generosity from people to support the work that we do, and it's our duty and responsibility to use these funds really effectively to benefit patients and our staff. There are a fabulous array of schemes that are described within the report, and support and equipment which really have substantially benefited our patients, families and their staff. So from this board, many thanks to all of you for the real generosity that you have shown us and our services. So thank you. Does Julie wish to comment from Audit Wales?
Good morning. Can you hear me okay?
Thank you.
Hi. No, nothing really further to add. You've got our audit of accounts report there in your pack and item 3.2, and I think just briefly, we intend to recommend the Auditor General signs an unqualified audit opinion, and he'll do that. We have an appointment to do that tomorrow, and I haven't got any significant issues to draw to your attention, but happy to take any questions on any element of the report.
Thank you, Julie. Has anybody any comments, Ewan?
Yeah, no, nothing on the accounts really. It's just obviously the fact that we're sitting on £5.8 million worth of charitable funds there. Probably more given where the markets have gone this year. A lot more since these accounts are finalised. It's whether or not we can do more or should be doing more to advertise the fact that we've got these funds and encouraging people to actually spend them.
Yes. I think that's certainly something that should be pursued.
I think that's we had a discussion this morning as part of the preparation for the March meeting. I think we've got plans in place to look at that particular issue and to try and review ensuring that people are aware of the charity, but also the fact that there are fund holders within the charitable trust that I'm going to sort of ask, well, what are your plans to spend the money, etc. So I think we've got plans in place on that. It might be useful, Chair, to ask Mark and Gareth if they've got any comments. Both of them have been very heavily involved in the putting together the report, if that's helpful.
Mark, Gareth, any comments, please? I think you're on mute, Mark.
Apologies for that. Nothing new to add really that Julie and Rob have said, other than just the process this year with Audit Wales and the earlier deadline that we've met has obviously been very good, and we're looking to bring that forward again for next year so that this is earlier and smoother. So other than my thanks to the team, nothing really to highlight.
Thank you. Gareth?
Thank you, Chair. No, nothing further to add other than what Mark and Rob and Paul and Julie have mentioned. Just to express my thanks to the rest of the finance team for all their hard work throughout the year. This is not just as part of the accounts that they do sterling work. They do sterling work every day, working with the fund holders and getting donations through to the charity. So just to note my thanks to the rest of the finance team in that respect.
Thank you. I think we note that. So, having received the draft accounts and considered the audit findings presented by Audit Wales, could I ask if the trustee is content to approve the annual report and the accounts for 23-24? Yep, happy about that. Thank you. We will start the board meeting in 4 minutes. Thank you.
Thanks, Julie.
Thank you, Julie.
Thank you all.
Chi gyd a croeso i'r Bwrdd Iechyd Prifysgol Aneurin Bevan. Welcome to you all today, our guests and our committee. Today's meeting will be recorded as usual and published on the Health Board's website for viewing following the conclusion of the meeting. I have a number of apologies for absence. For noting, Dr. James Calvert, the Medical Director, and Dr. Liam Taylor is attending on his behalf. Peter Carr, the Director of AHPs and Health Science, and Richard Clark, Independent Member. In terms of declarations of interest for noting, please could I ask if there are any declarations of interest arising from any items on today's agenda?
Chair, I'm a patient of the Tredegar practice.
Thank you. Any further declarations? No. The consent agenda business. Please can I ask if any member wishes to bring forward any items from the consent agenda for individual discussion? Otherwise we can leave them as read. We have taken the corporate trustee business separately, and could I then go straight on, please, to the patient experience and public engagement report. I'm very pleased to welcome today's meeting Kathleen Connor and Anne Montford from our urology service, along with patients who've been using the app, and we're very pleased to see you here this morning. Thank you. Paul, you're going to
Yeah, so
introduce this.
as the board will be aware, in 2023 we implemented the My Medical Record app within the urology service, with the aim of really empowering patients to be more involved in their care, and it's been really successful today. So really delighted that Richard, Philip, Kath and Anne have been able to come today to tell us their story. So yeah, over to you guys.
Thank you. Good morning. Aneurin Bevan Health Board is the first health board in Wales to implement the digital platform My Medical Record. It is used in 16 health boards in England, not only for prostate cancer, but for other specialities too. Not all patients require the same intensity of support and can self-manage aspects of their care at home. We currently have over 300 patients on My Medical Record, and these have been identified as suitable either by their urology consultant or a member of the nurse specialist team. Previously, these patients would have a telephone review with the nurse specialists to be given their results, which could be a couple of weeks after they've had their blood test taken. By giving patients access to the digital platform, we have reduced their waiting times for their results, as they are available sometimes on the same day, but no longer than 48 hours after having their bloods, which also reduces the anxiety. They have increased access to clinical information and improved communications with the team. Patients feel empowered in managing their condition as they understand their symptoms better, so positive action can be taken to improve outcomes. Also, by taking these patients out of the nurse specialist telephone clinics, it means the nurses have more time to spend with patients who have more complex needs. As the support worker, I support the patients and also the nurses. I monitor the clinical tracker to ensure the patients have their blood test taken when they are due, and also monitor the messages. And I will alert the nurses when the blood test is received, and also if there are any issues, so then the nurses can contact the patients. And I will hand over to Kath.
Thank you. I'm Kath. I'm one of the nurse specialists within the urology department in the Royal Gwent. Yes, we're very happy with this service and the way it's gone. We have our patients here with us today, and initially how we get them on the programme is we chat with them in clinic when we're surveying them for their PSA results, ask them to come along to a one-off workshop. That workshop is very important to our patients because it's full of education, advice, and it's got lots of self-help links and cafes and self-support groups that the patients can log on to and fully embrace learning more about themselves and their cancer journey, and hopefully getting support from other patients alike throughout the links and all the rest that we've set up on it. And I'm sure they'll give you their own rendition of that in a moment. But we're very happy with it. It's been very successful in our department. As Anne said, we've got over 300 patients who have been taken out of our telephone clinics. So that equates to roughly about 600, maybe 1,000 outpatient telephone appointments a year that we've put now into this system, where everything is logged on, all their roster of PSA blood tests they can see for up to 10 years, when they're due, etc. We look at those, and if there's any sort of breaches of their PSA parameters, we call them and we decide what we're going to do next, in relation to any further investigations. So we've really sort of taken out quite a lot of service out of outpatient department and put it into this. And as Anne said, it allows us to give more time to more complex urological cases that come through our nurse-led clinics. That's all I've got to say, unless you've got any questions.
Are there any questions? What is the patient fee? Oh, well, a patient feedback is going to be given.
Yeah, you're welcome to stand up and have a chat and give your version.
I usually go first, and then I've done this in all the focus groups we've had. Richard is a friend I know through sport, so we've been through similar experience. I think everybody knows you mentioned cancer, and it's everybody, well, it's a major issue. So for me, I went through the process of treatment. I came out of the treatment, and this app or this platform was then introduced. So for me, in terms of the platform, it's excellent in terms of communication. One of the key elements that I think is the way that it was introduced, the amount of information, how it was communicated to people in a sensitive and educational manner, enable people to use the platform efficiently and effectively. I think you're very lucky in Aneurin and Bevan to have this team behind the app. I think that's what makes it so successful. One of the key things is being able to get your PSA results quickly. So for me, coming in afterwards, it's always, you wait for your PSA and it's always, oh, what's that going to be? So very nervous. But that's a key element. And the amount of information that's in there, and it's presented in an easy to understand format. So many people from so many levels can look at the information. You've got videos, you've got testimonials, all kind of things. I don't necessarily need all that. I need what's relevant to me. So I don't use it a great deal, but knowing it's a bit of a comfort blanket. The communication with the team is excellent. You send them an email, they respond back either the same day or next day. For me, that's amazing. So all in all, the platform is great. It has its limitations. It's not linked to any other systems, which is disappointing. GPs, for example, I think it's key to integrate with GPs. Other departments that maybe people have multiple illnesses, so have it linked into other systems. So that's just one of the downsides of the platform. I'd be interested to know the benefits from the platform in terms of what it's saving. You know, is there a cost-benefit analysis? What does that look like? So I'm interested in that kind of stuff. So I'm assuming all that's been done internally, but given the challenges that health service has, I think those are some key elements as well. So for me, massive success, great team, should be rolled out further.
Thank you. Thank you.
Hi, I'm Richard Drinkwater. As Phil said, we've known each other a very long time. It was just really weird how going to focus groups, I'm like, we're in the same gang. My journey with cancer started literally 3 years ago now, with my initial diagnosis, 49 years old. Felt like I had the rug ripped from under me at that point. The support I've had from day one has been gold standard. And I'm not saying that because of the company I'm in now, I'm saying it's just the truth. From diagnosis through all the checks and everything else, to having a radical prostatectomy and everything that brings with it, to a young guy under 50 years of age, is massive. But the support I've had all the way through has been incredible. You know, I thought pretty much everything was coming to an end. You know, and you're told infertility, incontinence. I think I've got a lot of living left to do. So sort of went through it, and then you go back into the cycle of having PSA tests again. And it's like sitting underneath the sword of Damocles. Because you go in, you have your blood test, and you wait. Days seem like weeks. Literally, as you're waiting for that to come back, your fingers are crossed it's coming back zero, a real baseline. If you haven't got a prostate, you shouldn't be having anything really. And it's purgatory you go into for that period of time. So when Kath and Anne approached me about going on to the self-management, I jumped at it. The training that's given to us is great. Real sort of simple terminology used, introductions to the web portal, everything else, to the point that you get phone calls saying, I haven't noticed you've logged in. Have you done this? Have you done that? Your hand is held. You go in, you start using it. You get all the prompts, everything else. I know when I've got to go and get my blood test done. My little stickers arrive. I steel myself. I pop down to the Gwent. I get the blood test done. 24 hours later, I get my results. I just log in, there. That anxiety is gone. I just hold my breath a little bit now. It's brilliant. But also within the portal, there is a wealth of information about self-care, signs, symptoms, things to look for anything else that could occur post-op. And it's all coming from a trusted source. I'm not relying on Google and whatever I can find. I'm finding 3 versions of the truth. It's a trusted source, so I go there. It is a digital wraparound service, which is fabulous. But behind that service, you've got wonderful people like this. And as Phil said, I can drop an email. I get a really quick response. 24 hours is usually the worst case. Or depending on the query, I get a phone call. I feel I am just being cared for, I'm being looked after. And it does allow you to manage that post-cancer journey. Because those blood tests, every time you're thinking, it's the what ifs constantly, and they dispel so quickly. So as a resource for someone like myself, this had an operation, this come with its own difficulties and challenges post-op as well, but I'm living cancer-free now. And I know when it comes to my blood test, I'm not in that space where I'm going, oh my God, waiting for prolonged periods. It's literally 24 hours. And if I do see something or I experience something that don't feel right, I ping a quick message, I get a rapid response. So allow me to have quality of life, to carry on doing what I love, to play squash, go cycling, to be in work, and just everything ticking along relatively naturally. It's worth every penny. Cheers.
Thank you. Thank you very much indeed. My husband also has had prostate cancer, and I know exactly what that weight is all about. And it must be so great to have this team behind you and that absolute assurance, particularly looking at, if you get these symptoms or those, what can you do about it? So I think it's really great. I think, Paul, we need to talk further about how we link this with the other medical specialties and the GPs, because it seems to be such a good development.
Yeah, so we took a paper to the exec committee about 3 weeks ago on the scale and spread of my medical records. We're now looking at what areas other specialties we could potentially support with the platform going forward. So working with the team on that.
Good, that'd be great. Are there any questions? Oh, sorry.
That our compliance, and it is, as I said, could be so easily rolled out with other specialities, because our compliance for patients doing their blood tests is far superior on this system than it is on the telephone clinics. So it is definitely worth thinking about rolling it out.
Good. Are there any questions at all, Paul?
Say huge thanks to you for coming to share your patient journey today, because I think it's been incredibly difficult. I think it's one of the biggest growing areas of cancer, sadly. So I think sharing the journey and being as open as you've been, I think has been incredibly helpful. This is a sort of a Kath, and I think also to Anne. I chair the Charitable Funds Committee. If you've got initiatives or ideas or thoughts about how you can develop or sort of ideas of fundraising that we can help you with, or projects, then please be aware that we've got a Charitable Funds Committee and there's really good ideas from other sort of parts of the organisation about what they've done. And so please, come to us, put a proposal forward to get some ideas, initiatives, so we can help and support you and the patients. And I think, it's incredible to hear your voices today, and also about the services you've been provided by Aneurin and Bevan. I think there are people who criticise the National Health Service in Wales, but from our point of view, I think you evidenced right from the heart of the community about what we are trying to do and help and supporting individuals within our community. And thank you very much for coming.
Thank you. David?
Just say thank you very much for that. This is a great example of a piece of technology that is supporting our patients and supporting us to do what we do. And it's a great example of starting with something and showing that it works, and then we can scale it. And I think if we took that approach for a lot of our services, we would get much better.
Yeah, well done.
Penny?
Yeah, I just started. Thank you so much for that. That was really good, and I know that you'll pass on the message to others as well, which is good. But I'm just wondering if we could go forward with something like breast cancer, which is a huge subject as well. You know, to have that wraparound, you know, at the end of the phone, that wraparound support would be superb. So yeah, well done. And let's hope this is the start of something new.
Yeah. Thank you. Anything further?
Just
Yes,
just to summarise, so thank you. It's a hugely powerful story, and I was involved in some of the early kind of work to kind of test whether we were going to progress with this particular app that we knew was working in England really effectively. So to see it kind of working in practice is brilliant. And I think, as you said, you've got those days of waiting. Sometimes we bring in people back to clinics that they don't need to, when you can have a quick kind of update off your phone, and then that enables you to live your life, as you said, in a much more, and take control of your situation as well, feel as you're in control of the situation. So we are keen, we do recognise there are other kind of specialties that would benefit from this particular approach, and we are committed to look at how we can roll it out. I just want to pick up on your point about the integration with other systems. That it's a constant battle for us, and we're continuing to work on to make sure, you know, everybody's got access to all the relevant information, whatever medical profession you see, whether that's the GP or in a hospital environment. So we're continuing to work with that as part of the national work, as well as some of the work we're doing locally. But it is really, you know, it is an important point, and a useful one to get that kind of feedback from yourself in terms of the benefit that would bring. So just want to thank you all for sharing your story today as well. It means a lot. Thank you.
Thank you. Thank you very much, and thank you so much for coming in. And keep well. Thank you very much.
Pleasure.
Yes, certainly.
As long as we can give a little back.
Something to be proud of. Thank you very much. Thank you. Len? Thank you. Thank you. Might we move to item 6.1, the report on the GP partnership, Dr. J. Ahmed and Dr. J. Allinson. Please, Nicola.
Thanks, Chair. So we produced a report to give an update on the situation with the GP partnership. Dr. Ahmed and Dr. Allinson, who hold contracts for 8 of 68 of our practices across the Health Board. 5 of these 8 previously were managed practices of the Health Board. The paper sets out quite a lot of detail on the timelines and the process by which the contract was awarded. It's worth highlighting first partnership that the GP partnership took on in this area was Liswerry, which was done without the Health Board's involvement by joining the existing GP partnership. And it's at that point that the partners went through the level of vetting and scrutiny in line with the kind of medical professionals list, which a GP needs to be on in order to be awarded a contract. After that, we, as a result of 2 contracts being handed back to us in Pontypool, we went out through the normal vacant practice process, and the partnership were awarded the Pontypool contract in October 23. And then in January 24, as a result of our managed practice, Tredegar practice was awarded to them, and then 4 others in April 24. And these were 5 practices that were being managed by the Health Board, and you know, faced a number of challenges around the sustainability and ability to recruit GPs. The partnership put forward a plan which was to improve the sustainability of these practices by recruiting more salaried GPs, having greater access to the GP market and supporting it through a back office function which was considered a more efficient model, which was well recognised in England. It was a standard GP contract that we awarded in line with our other contracts. And it's probably worth just teasing out E. Harley Street, which is referenced regularly. That is the name of their back office function that they then subcontract their back office functions to. I think it's fair to say the last few months we've seen significant escalations to the Health Board, primarily around the Bryn Mawr practice, where a number of representations were made by the local councillors, MSNPs, and then patient feedback. There were also concerns being raised, and to some of those were directly to us and Welsh Government around concerns around locums not being paid and issues with HMRC pensions and also suppliers not being paid. So a number of concerns that were very serious that the Health Board took very seriously and put the partnership into a formal escalation of enhanced monitoring at the end of October last year. And since that time, we've been in weekly or bi-weekly meetings with the partnership to work through what the issues are and what some of the evidence was also there supporting what we're hearing from the communities. So as a result of that, the Health Board's taken a whole range of actions. So as part of the enhanced monitoring process and the meetings, we've done a number of patient safety visits. The primary care team have gone out and done a number of patient safety visits in line with our frameworks. We've sat down and done, the team have done quite a detailed financial review with the practice, and we've needed them to openly share their financial information with us, which is their information, but they've been fairly open with us, particularly in the latter period. And our finance department has been working with the partnership to get underneath some of the financial issues as to why some of these financial challenges are presenting for the partnership, resulting in staff and suppliers, locums and suppliers not being paid on time. We've reviewed lots of the data we've got available around clinical sessions, appointment data, access to the emergency prescription service, presentations to say our ED departments to see if we can see any particular trends since the partnership took over. And whilst there's a fairly level of continuity, consistency in a number of practices, there's one or two that do show a reduction in the number of appointments delivered in one or two areas. We've put in additional transitional support where our frameworks allow us to do that. So we've got a framework where there's a high use of locum, we can help them financially through the sustainability framework, and we kind of use that to support Bryn Mawr just before Christmas, and we've recently done that to support Pontypool. We also put in additional GP sessions at Bryn Mawr because we were picking up some of the reduction in clinical sessions and some of the challenges the local people were having in terms of accessing doctor appointments. So we put in additional GP sessions at Bryn Mawr. We've been working with Llais. They're also doing a number of visits to all of the practices and other GP practices to listen to patients' views themselves, like an independent kind of view of that as well. We've sought legal advice in terms of understanding the contractual position. We've also commissioned internal audit to undertake a review of our contract award process, which is a standard process in line with the Welsh Health Circular. But I think given the questions on the Health Board around its due diligence in the contract award, I thought it was an important that we commissioned that internal audit for assurance or highlighting any issues that we should have picked up. And we've been having, I personally, along with my colleagues, and particularly the primary care team, have been having regular meetings and communications with the local councillors, MP, MS colleagues and Welsh Government to keep them appraised of the situation. So in terms of where we've got to, following discussions with the partnership in the last week or so, the partnership have agreed to mutually hand back the contract of Bryn Mawr back to the Health Board. This normally would involve a 6-month transition process, but we've agreed that we will use February as our transition, and the Health Board will take the partnership back, the practice back on the 1st of March this year, so in the next 4 weeks. In the meantime, we've kind of grouped the practices that we continue to be most concerned about that are under the management of this partnership. mainly at this stage is Tredegar, Aberbeeg and Bryn Tirion and Pontypool, albeit Pontypool does have a greater level of salary GPs, regular staff that we think possibly has got a greater line of sight to sustainability. And then Lisweri, Blaenavon and Gelligay, there's been less concerns raised about those partnerships. That is nothing different to what we pick up as general primary care challenges. So we focus in on those kind of our second group, as I mentioned, Aberbeeg, Tredegar, Bryn Tirion and Pontypool, and we will be putting in enhanced oversight, and Leanne can give a bit more detail in terms of the specific work the primary care team will do now going forward, in addition to working with this partnership. And what we will continue to do is on a kind of contract by contract basis, work with them now in terms of their recovery plan. The other element that we are working closely with them is continued assurance around payment of outstanding locums and suppliers, because we are concerned that that is still an issue for them. And also seeking further assurances around HMRC and pensions, because whilst we've been assured all of that is now above board, and there were some issues in the beginning in terms of getting pay-as-you-earn codes, and there was a transition issue. We are told all that is now above board, but we have been picking up concerns through individuals that they are concerned that their personal accounts are possibly not up to date. So we are trying to seek further assurance with the partnership around those particular issues. So Leanne, I don't know if you want to just explain a little bit more about the work the primary care team will do on the practices we've still got a number of concerns about.
Well, you've referenced the audit already, Nicola, in terms of the process that we've gone through for the vacant practice panel. In line with the enhanced monitoring that was put in place for Bryn Mawr, the other 4 practices will have the same level of scrutiny and support from the team. In addition to that, the metrics that give us an understanding, because our prime concern is obviously access and service provision for the local populations, will be monitored on a weekly basis. And that information will be fed through, as we've discussed, into the executive board, and then sort of up to board should there be any escalation requirement on that. There has been a request with the partners to work with us on the recovery plans for those other 4 practices, and we expect to see some updated analysis and financial information that gives us the assurance that we need, that we've got sustainability in place across those practices as well. And as Nicola's mentioned already, the enhanced support from the primary care team for fortnightly meetings with the partners and regular drop-ins to those practices, I think will give us some further assurance in terms of progress and I guess allay some of the concerns and worries that the communities and local populations and staff have for those practices.
And I think it's just to reinforce, we are very concerned with staff who have not been paid on time, suppliers not being paid on time, because that does present a risk to the future provision of services in all areas. And we are working constructively with the partners who are working with us. But it is, these staff are employed by those partners, and therefore is a limit on what our ability to step in at this stage is. And I think it's just important to reinforce that, which is why we are working closely and constructively with partners directly.
Thank you. Well, the board has gone. Yeah. Do you want to add something, Rob?
Just in terms of a little bit more on the due diligence. So we've done a financial due diligence review with the information provided by the practices and our own intelligence that we hold, just to let the board be aware that other than the late payments to locums and the pension contributions, which we have concerns with, they were the key points that emerged as concerns. We have had and we've witnessed settlements around pension payments that they put in place, so it's just a matter of maintaining a check on that. In terms of what's driven some of the issues with the practice, I think it's worth just noting that from our review, specifically in relation to this GMS contract, it was the aspirations as part of the takeover plan around salary GPs, as Nicola's alluded to, that hasn't been achieved. That's led to spiralling costs outside of the intended delivery plan. Obviously, their ability to secure temporary staff then to cover has been exacerbated by non-payment of other doctors. And then one other thing I think we would have drawn out with with the ability in terms of the financial analysis is the ability to for them to improve on some of their operational management arrangements, but obviously that's within their gift, and that's where we now need to wrap around that. And then finally, from a financial perspective, if the practice had come forward a bit quicker, we probably could have helped with our established financial support policies that we have in place across the health board for all our practices, and we're looking at that now in terms of the sustainability and the future plans for other portfolio practices as well.
Thank you. Are there any questions on this? We have discussed this before. No?
Can I just make a point? It seems incredibly naive that they didn't come forward with when they first had problems. This could have been sorted out much quicker, could it not? You know, like you could help. You know, the sustainability, and you've offered to help and support where it was there. Why didn't they come forward to access it?
I can't answer that. I think that from our conversations, I think they were just trying to work through their own difficulties and kept trying to recruit as much as they could, and it just didn't happen. And I can't talk for them, obviously.
Are there any questions from the board? I think we've had a thorough review of this, being in a very difficult position in that we don't employ the staff, and this is subject to a legal contract that does limit what you can do, but it is really imperative that we maintain a good quality access to primary care, particularly in the areas in Blaen y Gwent that have been subject to being managed practices before. Are there any questions from the public?
Thanks, Anne. So we are joined by a group of guests today who have keen interests in the matters you're discussing.
And we're very pleased to see you. Thank you for coming.
You've agreed for 3 of the individuals to ask questions which we've received. So if it's okay with the board, we'll take each individual question separately. And I believe then the Chief Executive Officer or the Chief Operating Officer will address them. So the first question is going to be asked by Councillor Helen Cunningham.
Oh, hello. Hi, Chair. Hi, Board. Thank you for having us today, and it's really welcome news about what's happened with Bryn Mawr. My name's Helen Cunningham. I'm Deputy Leader of Blaen y Gwent Council, and I'm also Councillor for Llanelith Ward, which has Aberbeeg Medicine Practice within it. And although it's welcome news, this can't be the end of this. For patients, there's not a consistency of care, there's not confidence in care. Patients in Aberbeeg are unable to get appointments for months on end, and they're told to go to Neville Hall when they can't get appointments. They can't get test results and they can't get medication. There's medics today that remain unpaid, some of them are here. There's people today who've lost their jobs because what's gone on with E. Harley Street. So my question really is what's being done to address this crisis in primary care for patients in Aberbeeg. Our view is that E. Harley's presence in Blaen y Gwent exemplifies the continuation of the inverse care law. It's alive and well at the moment as long as E. Harley Street remain in Blaen y Gwent, and I would say remain in Wales.
Thank you.
Yeah, thank you. And, absolutely hear your concerns. And, when you look at some of the information, particularly for Aberbeeg, where there isn't any kind of regular salary GPs, that is a real concern for me. And obviously is an area that's been of concern when we were running in terms of trying to get that regular model. So, as I said, it is one of the key areas that we want to focus on now as our next phase, if you like, of practices that we need to really get underneath the issues, and what can we do under the contract at this point to support and I suppose supplement the service that's being provided through the current partnership while we're working with them. So I don't think anyone want to add to that, but that's where we and the same applies to Tredegar, where we'll do more than what we were doing with Bryn Mawr in terms of getting underneath some of the issues that we're facing, and what can we do to supplement, as I said, the service that's being provided through the partnership, which is what we did in Bryn Mawr. We added additional locum sessions on there to try to mitigate some of those issues. And I know I've shared with some of you before in terms of sometimes the issue is around how the front end of the practice is being run, in terms of the telephone systems, getting through, being talking to somebody, and how do we make sure that we support in that front end so that when there are doctor's appointments available, people can get access to them, because that has been a theme that we've picked up as well. So I don't think anyone want to add anything on.
I think there's a wider piece for us anyway, broadly. I think sort of across Wales are on the primary care model anyway, that I think we're all struggling with, which I know is not of importance to you in your local communities at the moment, but I think there is something for us to feedback via the policy route as well about the model is outdated, it hasn't really changed, and we need to do something different. It's really important we deliver sustainability in primary care. It's the bedrock of our healthcare delivery service, and we want to give the practice and the partners the opportunity to address, I guess, the issues that they've experienced so far in Brimau in particular, but across those other practices. I think with the support of the primary care contracting team, regular visits, working with them to see if we can recruit those salaried GPs in particular to support the continuity of care piece, because the locums are a huge challenge for you and for us as well. So that has to be sort of our holy grail on this. But we have asked for a short period of time to work with the partners to see if we can deliver that more sustainable and improvement in quality of service. And as I've referenced already, the metrics that will be tracked via the executive board on a weekly basis will give us pretty accurate and up-to-date information in relation to whether we're seeing any improvements or not.
Can I just briefly add, so one thing I meant to update at the end of my presentation of the paper is that we will bring an update to the board for the March meeting, which is on our next meeting. And I know when I met with the councillors of Brimau, Aberbeeg and Tredegar this week, that I would commit to another meeting in a month's time where we will provide, so it's about give us a little bit of time to work through some of these issues, and we will come back to you in a month's time through the local meeting to update you on how we're progressing as a health board with these discussions. And I'm happy to keep that regular dialogue with you as I committed to this week, to make sure you are regularly informed, and at least we keep you close to with us in terms of how we are making progress.
Thank you. So I'm going to invite Councillor John Morgan for the second question.
Right, thank you. My name is John Morgan. I'm a councillor for Georgetown in Tredegar and also a cabinet member for Regeneration in Blaenau Gwent. I'm lucky. I'm with the other practice in Tredegar, right, the Sayal practice, which I'm aware has 4 doctors, 2 nurses, a paramedic, 3 receptionists. We consider we moved from the surgery in Beaufort to the Tredegar surgery. We were really worried about moving because of the service we're having. But to be quite fair, we think we know we're having the same service there. So I'm here to speak for the other 6,000 people in Tredegar that are having a service which is not up to the service they had before E. Harley Street took over. First of all, these are the words of a lady I spoke to yesterday who rang me about the Bryn Mawr situation. Great news for the people of Bryn Mawr who no longer have to put up with E. Harley Street. However, people in Tredegar have a poor, inadequate service, and a service that is continuing to deteriorate day after day. E. Harley Street provides a service that fails their surgery, their staff and their patients. I sincerely hope we do not get transferred, I sincerely hope that we will be transferred back to the Aneurin Bevan Health Board as soon as possible. To me, that speaks volumes about what they're having at the moment. Some of the questions I have you've actually answered now, but because I've written them down, I'll just go through what I've actually written down. What measures the Health Board taking to monitor the service provided, doctors on duty, appointments available, number of patient times and referrals to pharmacists for antibiotics because the doctor is not available, or referral to the service in Neville Hall, which is what Ellen just spoke about. I think you've actually answered that question. Knowing the reputation that E. Harley Street had in England, in Northampton and other counties, what vetting, references, procedures did the company have to go through? I think you partly answered that by saying what has happened in Wales. by withdrawing the E. Harley Street contract in Bryn Mawr, this is an admission they do not meet the standards required for the people of Bryn Mawr. So how long do patients in Tredegar have to put up with this inferior company before you decide to act? On what I've heard this morning, I would like to ask if you would regularly meet Blaenau Gwent councillors so we can have an update on what's happening and bring to you what we are actually being passed day after day. And lastly, I spoke to a lady this morning before coming here who came up and said, what's happening with our doctors? And she said to me, my own writing now, I can't even read my own writing. She's proud of Tredegar and its links with the NHS. That is considered the spiritual home of the NHS, and proud of the fact that Aneurin Bevan came from Tredegar. However, she said that she's been told when she went to the doctor, she was sent for sort of one sort of examination, and it wasn't the examination that she should really have gone for, and she was told by the practice, oh well, we're a private company. So that person said to me, you know, this is like you could write a second volume of the Citadel with this, you know, especially with a company by the name of Harley Street. So they've seen it as sort of privatisation through the back door. And thank you.
Thank you. Thank you very much. Yes, so I'll pick up a number of those issues. I'll pick up the last point because I know a few times it's been referred to as privatising the NHS through the back door. All GP contracts are private independent contractors. It's the model that's been in place since the NHS was formed. Whether it's you're a dentist, a GP, an optometrist, a pharmacist, you are private independent contractors. And this partnership is the same. What's different is they do run and what's called, and I agree, the name is E. Harley Street Solutions, which is where they run all of their back office admin functions. And that particularly has been a kind of a focus of attention. So I'm just kind of clarifying that it isn't different. It isn't a different. The bit that's different is the whole basis of the model was that you have GPs who live, work in that community and they stay there. They not run from a distance. I would agree that is a different model, which is quite well established in England, but has not really been, as a result of lots of GPs not wanting to run their own business anymore and want to maybe work in a salaried role. So that goes back to Leanne's point about, is the model still fit for purpose for the future, which is something we are all discussing on a regular basis as a national level as well. Going back to the point, so I understand that, you know, my own views is we've got two practices running out of this beautiful new health and wellbeing centre in Tredegar. It's not what you'd probably design, it's not what I would design, but it is kind of where we are in terms of the two partnerships side by side. When you look at some of the data that sits underneath, notwithstanding the concerns are very consistent around being able to get through to the receptionist, get access. When you look at the appointments delivered, which is what we regularly report on, there are more appointments for the practice size, for the population size in Tredegar than the other practices, which possibly is reflective of the needs, but it doesn't show in terms of the appointments being delivered. Notwithstanding, people can't seem to get through. And the other point you raise, which is people are often being, say, go to Neville Hall. The one or two areas where there's a slight change in the pattern in the data is an increase in the people presenting from the Tredegar practice in the last 6 months to our ED or unit. So that is consistent with that. So the data tells, some of it fits with the narrative, some of it doesn't. But that's why we need to get underneath this to understand it. There are a number of salaried GPs that work in Tredegar, which is slightly better position than what we've got in Abergig. But as you say, there's still huge reliance on locums. So the same issues and the same action will be taken on Tredegar as I described for Abergig. But absolutely hear what you're saying, and more than happy to work closely with the Tredegar councillors as we navigate our way through this particular challenging period. Leanne, do you want to add?
Yeah, I think it's just really important to add as well, sort of that in terms of the contract that currently exists at the moment, technically there is no, as hard as it is to believe it for you guys, there is no breach of contract. So it's really important for us to maintain good working relationships with a partnership, because had we got into a difficult legal conversation, we wouldn't be able to act as quickly as we would have in terms of the take back of Bryn Mawr. They have voluntarily resigned that contract. in the interest of the local population. I think sort of noting the position they're in. So I think it is really challenging when that legal framework is so difficult for us as well. I think, but it's just important to reference that working alongside them, I think, will help, I think, in terms of expediency or worries as well, which is why we've been able to achieve what we have as quickly as we have with Bryn Mawr, rather than getting into an elongated legal challenge or battle.
Thanks. And the third and final question comes from Councillor Tommy Smith.
Thank you. I'm Councillor Tommy Smith and I represent the Srawi ward in Tredegar. And my question's a bit more generalised around where it went. Given the resignation of the GMS contract at Bryn Mawr Medical Practice, what analysis has the Health Board undertaken regarding the troubling pattern of unpaid staff, tax and pensions issues, and the substandard care for patients at surgeries run by Harley Street? What steps have been taken to review their continued involvement in managing other practices within Blaenau Gwent, namely Tredegar and Aberbeeg? And what contingency plans are in place to ensure continuity of care and patient safety should similar challenges arise in the future? And Chair, can I just add that speaking as a Tredegar councillor, and I speak from the heart here, the Health Board has just spent £19 million on Tredegar Health and Wellbeing Centre. And I really have concerns for reputational damage to the Health Board and what this organisation is doing to yourself. And I was particularly pleased to listen to the patient journey this morning at the beginning of the agenda. But I feel that the residents of Tredegar are not receiving that patient journey because they're not being able to see a GP to get to the next step of their journey. And I'll leave it there, Chair, but I'd like to associate myself with the comments from my two colleagues.
Thank you. Thank you. Yeah, thank you. And hopefully I've addressed a number of those concerns through the previous responses in terms of, I'm just going to ask Rob just to kind of come in again on the financial, what is it, what we're able to do or not unable to do around payment of staff, and then Liam, if it's okay, I'll give you the opportunity to kind of respond on those kind of patient safety things at Tredegar in particular. And before I do that, I just want to add, because there may be other people listening into this area, the same position is the same for Bryn Tirion and Pontypool, which are the other two areas outside of Blaenau Gwent that we are also have the most concerns about and are working in the same way for those communities as well. So I just wanted to take the opportunity to reinforce it as well. But anything you want to add, Rob, on that?
Yes, I think it's important to note from a health board perspective, we aren't employers of these employees and locums that the practice is engaged. So what we can do is, now we're aware of it, and what we have been doing is putting pressure on the practices to actually make those payments. We realise and recognise that the reputation of the practices currently is difficult in terms of them securing a medical presence in their practices because people think they may not get paid. So there's a vicious circle here. Part of what we've been able to do when we were made aware is apply our Aneurin Bevan Health Board support funding mechanisms, which are open to all practices. We're not treating these practices as exceptional because we've got to be equitable to all our practices. A lot of GP practices across the UK are struggling at the moment for various reasons, so we do need to be cognizant of that. In terms of where we are putting additional support in, we are requesting, directing as much as we can, that the payments for locums that are outstanding, the payments for pensions in particular for staff that are outstanding, and HMRC, which is more of an issue for the company owners themselves really, are priority payments made from the support we're giving them. Going forward, part of where we would like to see the practices and the portfolio practices remaining with the company is to get a bit more grip and control in terms of their operational and financial aspects of what they provide as a service, because there is an opportunity, and this is how general practice operates through the GMS contract, is the more they do, the more they get paid. So there's different mechanisms within what is a very, very complicated contract arrangement for them to provide more services to patients, and they will get paid and they will make a margin on that. So that helps the sustainability of practices generally. And from what we've found with the reviews we've done so far, is they haven't optimised that. So we've met with them personally, well, on the teams, and started drawing out some of these more pointed things we would expect to see in place going forward. But again, that's influencing. We don't have a direct contractual relationship to go in and directly do things. Obviously, with Brimell now, we will be in a different place.
Liam?
Yeah, so clearly these practices, there's a range of challenges. And as a health board, our first priority is ensuring that patients have access to safe and sustainable care. And alongside that goes the other things around ensuring those who work there are paid and that we've got a long-term sustainable model of care. So in terms of the first things, we delegated teams of doctors, experienced clinical director, primary care, senior nurse and a senior contracts manager to visit each of the practices, and we're on the second cycle of those now to check on those things. So, and the feedback we've had is that there aren't immediate safety concerns. There are things, and if you visited any practice, you could find things that could improve, and there may be more things that could be improved in some of these practices than others. But in terms of things they've done, for example, so they've listened to samples of patient calls to make sure that patients are being given the right appointment in the right time frame, and they had no concern around those. They looked at things like the processes for monitoring, things like warfarin, pure long-term drugs that they monitor, like methotrexate, things like diabetic reviews. They've got programs to do those. So no immediate concerns. Some areas for improvement, and those visits will be ongoing, and we will be working to address some of those specific things where we can support them to do things better.
Thank you. Are there any further questions?
That concludes the questions and answers. We'll hand back to you. Thank you.
Thank you. Well, we have been discussing this at length, and it is absolutely critical that good access and outcomes for our population is our critical thing for us that we must do. So we as you've heard this morning, we should do everything we can possibly do to ensure an effective service for you all. As you've heard from Liam, there are frequent patient safety visits, and we're working as much as we can with the practices to secure a solid and effective service for the population. But this is our top priority. We cannot have primary care not being delivered as we would expect to meet the needs of the population. So we shall be in constant contact with you. We do appreciate fully your coming today. You represent the communities. It is a community that has a number of health problems, and we are working hard, and this board is committed to working hard to solving those and improving the situation as fast as we possibly can. It is difficult because we manage a contract, and as you've heard, these are private contractors, but nevertheless, we will not stint from working hard with them to improve the service and to ensure that you get a much better service and the people get a much better service than they're getting at the moment. So thank you ever so much. Oh, yes.
Can I ask a question?
Yeah.
I didn't realise.
Go on.
My name's Ian Jones. I've been a GP salaried and partner in Blaenau Gwent for 20 years, and I'm one of the locums who's owed money. and I moved for sessions in Bryn Mawr surgery by coincidence in July and August last year, which should have been paid at the beginning of September. So a lot of people, loyal locums, are in the same boat. Oh, this money still haven't been paid. It's very difficult to put an actual amount on how much we're owed. But potentially a lot of these GPs, including me, are now thinking of going down the small claims route.
Yes.
Okay, so that then will push the problem further down the road. That Dr. Ahmed and Dr. Allison will probably end up over the next 4 weeks with an extra massive amount of money to find to pay, because there's no question that they owe the money. They do owe the money, so they've got to find it from somewhere, or potentially they could fail as a partnership, which would have a knock-on effect in the other part and in England as well.
Yeah. Yes, I think we are well aware of that, aren't we, Liam? And Liam is tracking that very, very carefully.
Sorry, can I please ask a question? So my name's Amy McChrystal and I was the practice manager at Bryn Mawr Medical Practice. With regards to what would count as sufficient notice in reaching out to you to begin with? Because I raised my initial concerns June last year with regards to fundamental issues that I thought were going to directly have an impact on patient care, but also on the staffing of the surgery. So I heard the comment to say, you know, if we'd come sooner, what would constitute sooner than June last year? You know, I was made redundant. I know that's not a topic for discussion for today, and it's nothing that you can get involved with. I'm currently moving out of my house, me and my children, because of the situation that I was left in, because I alerted members of the health board that there was a failing on Harley's part. You know, and that's continuing now. And I sit here and I'm very glad that Bryn Mawr has gone back over and that those staff can now get the support and the help, and the patients will get that support as well. But, you know, realistically, what sort of earlier notice did you need other than June last year, considering we were taken over in April?
I think the bit that we were saying is the partners should have come to us earlier. We're not saying, because obviously we're aware that you raised an issue with the primary care team, which they picked up and looked into, but the partnership in terms of coming to them with their financial challenges is what we were referring to, that they should have presented to us earlier, because we were having a number of meetings with them as part of the transition, but at no point did they raise the financial difficulties, which is what Rob was referring to about coming in.
And that's, I guess, what I mean is that not concerning enough in its own, that, you know, those
That's what we've
problems
picked up. That's what we've picked up.
Thank you.
Okay.
Yeah.
Thank you very much. Thank you. To the meeting. If we could turn to 4.1, update from the chair. Apart from my usual visits and meetings during the last 2 months, we have held the interviews to recommend the appointment for a new vice chair, and we're awaiting a decision. So I'll advise you of that as soon as I hear anything. I've attended and chaired 2 chairs peer group meetings at which we discussed the ministerial advisory group outcomes on accountability and the action flowing from that, including improved governance, board member induction, and the streamlining of accountability. Now, we do know that some of this report is being taken forward by the board secretaries, and Rani is on the working group to look at that. And apparently advice is going up on the rest to the Cabinet Secretary this week, I understand. So we'll wait to see what they're going to do about the rest, basically. We also heard about Health Technology Wales's strategy. I mean, it does seem to exist in a vacuum about which we hear very little. So we have asked them to provide us with an update on a 3-monthly basis so that we can contribute to their work rather than not realise what they're doing. We've had a Healthier Wales update. There has this red sheet of paper has come out with some sort of updates on what a Healthier Wales refresh is going to look like. but we do await a more definitive document outlining the strategic direction for the next 10 years. We've obviously talked about the regrading of Band 2 nurses. This is notice has been served on Swansea and other places. This is a UK-wide issue, and negotiations are continuing. We also discussed the Ministerial Advisory Group on Productivity and Performance and their focus, which is on urgency and emergency care, planned care and clinical support services. They did come to see us, was it about 10 days ago now? Last week. And it gave some feedback. Well, it was quite positive actually, wasn't it? So good things they pointed out. So we await their final report. They've got to complete their report by the end of March. And we've also talked about the prioritisation of objectives for chairs and boards, which has been accompanied by a discussion about induction, which we feel doesn't exist, which is difficult for new board members, and the updates for all board members on progress and process. So we're putting a bit of, we're trying to put a bit of momentum behind improving that. I attended a quarterly meeting of RPB chairs with the Cabinet Secretary and the Ministers. That was totally committed to the 50-day challenge, which nobody met in November, improved in December. But he's looking very much to us to advise on the interventions that actually do work and then to scale those up. The PSB I've attended, which is on the agenda, as is the RPB. I've attended 2 Care Action Committee meetings, which again have totally been swamped by the 50-day challenge and the improvement actions which are proving to be the most challenging and what good practice is available. We've been given a list of 10 interventions, which we're all obliged to adopt or justify why we don't. And there is a weekly return sent in by our RPB to advise ministers on what has and has not been effective. The reporting is somewhat onerous, but then this is over quite a short period of time. The Cabinet Secretary has also held 2 Health Board Chairs Assurance meetings, and I've also had my 3 quarterly assurance meeting with him, which covered his expectations for performance, Chair's objectives, and he's really interested in hearing of good and innovative practice that is being adopted within the health boards in the face of challenging service provision. He's really keen on that, so possibly our discussions on primary and community care can bear fruit there for the future. And we did have a visit from the Minister for Mental Health and Children last Thursday when she visited Tree Forest, which is here, the children's unit here. And I think that went very well. The CAMS service has definitely provided her with some food for thought on the way forward for those services. So that was quite a successful visit, and we're glad that she came. So are there any questions? No? Fine, thank you. On to you then.
Thanks, Chair. So the last 2 months since the last board meeting has been in the height of winter, and as anticipated, has been a hugely challenging period for the organisation and the wider system. You know, we've seen high levels of respiratory illness earlier and higher than predicted, really. This put extensive pressure on the system. We've seen high levels of acuity. There were times where our intensive care unit was full and we were at the point of surging. Resus capacity was really compromised. We've seen real improvements in package of care delays before Christmas, but then over that 2-week period they built up into a higher level. and exacerbated by high sickness levels as well, because obviously when you've got high levels of respiratory disease in the community, it affects our staff as well. We unfortunately got to a position on the 13th of January where we declared a critical incident, as you'll be aware, given the level of medical patients and pressures at the front end of the system, which lasted 7 days, and we maximised the opportunity of the extreme work of some of the staff in terms of stepped up and worked outside the normal ways of working to support the pressures in the system. The efforts were phenomenal, really, and our partnership working with the local authorities and the level of discharges we've seen that week bared fruit, and we see that in some of the package of care delay data that we've seen in the census data for January, but huge amounts of work. And we pick up more of that in detail in the winter plan as well. And I just kind of want to formally thank the staff for their resilience and hard work during that period, and the public for their kind of patience and understanding during those times where we had longer than we would, more excessive waits than we would ever like. I was just going to highlight our primary care system has also continued to be under pressure, as and particularly the attention we've had on the GP partnership we've just been discussing. And whilst all that's going on, there's huge pressure on us to deliver the ministerial priorities of 104 weeks to get to zero, and improvements in the diagnostic position in particular. And we've made some really good progress. We've seen about 1,000 ENT patients over 2 or 3 weekends, to move all of those in the 104-week cohort. Orthopaedics are ahead of schedule at the minute, albeit there's still some risks for the end of the year, and ophthalmology. We are trying to mobilise over 4,000 cataracts for the region to be treated by the end of March. So all of that work has been going on in the background and not lost momentum over that Christmas period. I just want to draw out, we can pick up later under the performance, but we've been patiently waiting for mental health as part of the recovery plan in terms of Part 1B, and you'll see in the report later that we've hit the target in December as predicted, with in excess of 80% delivery on children's and adults, which is fantastic and shows the commitment to getting that waiting list backlog down. So again, huge recognition for the work around that. And then just on the finance side, obviously this was another one of our kind of top priorities of focus over the last few months, and Rob will pick up in his finance report, but pleased to say that we secured additional recurrent funding from the Welsh Government, albeit some of it's conditional, and was in recognition of us delivering against some of the targeted intervention expectations, funding review, and delivery, the level of delivery of those savings, and kind of staying on track with our forecast. So as I said, this is picked up further in the finance report. And whilst all that's going on, we need to look ahead for 25-26. So we are progressing the new strategy, and I know we've had a couple of briefing sessions on that, but also in terms of the plan, the IMTP for 25-26. We've had the allocation letter, which Rob will update on as well, and we are continuing to face a challenging financial environment despite the positive progress on the funding, and the planning framework was issued setting out expectations at this stage. So there's a huge amount of work going on at the minute by the teams to make sure we pull together a plan. And I think, picking up on your point and the discussion we've already had today, that focus on prevention and primary care is going to be a key component of our plan, I think, next year, and has to be. So I'll leave it at that. Thank you.
Thank you, Nicola. Are there any questions to Nicola? No, it's very, very busy. So I think you're doing very well as a team to cover all the bases as you're doing. But it's very, very busy. Yeah.
Just to supplement, I think some of that, though I'd like to give you some sort of facts about sort of the sort of pressures the service, or sort of how well the services are coping with some of the pressures. I was in Family and Therapy's divisional assurance meeting yesterday. We had in the month of December a 44% C-section rate, a year-to-date average of 41%. Our induction rate was 37%. So just in terms of the acuity and complexity we're dealing with, and just to reinforce some of the messaging around the primary care resilience, we are now seeing, in terms of some of our stats, a growth of about 30 patients a month into our emergency departments or emergency units via sort of our primary care system. So it's really essential that we focus our efforts, I think, target our efforts on some of the things that we've talked about around primary care sustainability. But I know that sort of it's important that I share some of that information with you to let you know, I guess, what the teams are dealing with on a day-to-day basis.
Well, that is a bit of an increase, isn't it?
Really, sure. Pre-COVID, I think C-section rate was around 26%.
Yeah.
There's a, it has a massive impact on things like length of stay, resource utilisation, pressure on the teams as well and staff, versus a normal or a standard birth. So,
thank you.
Can I ask, is that the norm, that kind of increase elsewhere, or are we an outlier in that? Because that's quite a
there's multiple factors for that. I think sort of back in the day, I'm old school now, Phil, so choice was really pushed back at as an option, and I think that's not the case anymore. Post, I think, several reviews, we have pretty high levels of obesity as well. It means the complexity of the birth sort of is challenged. So we're doing a lot of work to get beneath it and understand it, but the prevention sort of agenda on some of this is mission critical for us.
Yeah, I mean, just from a clinical perspective, I'm sure Jen will come as well, but I think this is a nationwide trend, and there's lots of drivers. So increased maternal age is probably the biggest driver. Women having babies later in life, obesity and other comorbidities, diabetes and so on. And there's an issue of people are very medical legally, risk conscious. That's certainly an issue because when things go wrong, you read all about it, don't you? It was in the press this week. So I think, and the difficulty is most women who have their first baby by caesarean section will have subsequent babies by caesarean section. So you're locking in that someone.
Yeah.
Just to add, the increase in the numbers of induction of labour is significant because a high number of those convert into caesarean section. So the more women you're inducing, the more likely you are to increase your C-section rate as well. And a lot of it, as Liam said, is down to age, complexity, comorbidities, obesity, diabetes. So a number of things which make it high risk to deliver in a normal fashion. And as Liam has said, the number that go on to have subsequent C-sections is quite high as well.
Yes.
But it's, I think it's a UK-wide trend. I'd need to check the data, but there is definitely a trend up.
Yeah.
But just, when I qualified, I had obstetrics as an undergraduate, it was 10% was sort of the caesarean section rate. So
it's a big drift. Right. Okay. 5.2, report from SICE, the Gwent Legion. I don't know if it's going to be Linda or Lisa. Is it Linda?
Yeah. Sorry, yes, it's me, Linda. Lisa can't make it today, unfortunately. We've all been off sick. Yes, you want me to present the report or just ask for questions?
Just ask some questions. I think Lisa, Linda, if that would be okay.
Yeah, that'd be fine.
Thank you for that. Yeah. Are there any questions?
I've got a question, Chair, and Belinda. I see one of your major strategic routes forward is to look at a review of health and social care. I just wondered how you were going to do that. That's quite a big undertaking, and there are lots of other reviews and working groups and all kinds of things happening in that space across Wales. And I just wondered how you were going to do that and what was the time frame around it?
As I understand it, this will be a national slice exercise, and I think initially it'll be desktop and also gap analysis to find out where the gaps in knowledge are, and then we'd focus on researching those either face-to-face or by other means through data sources and so forth. So, it's a standard sort of research approach. Yeah, I mean, we will gather information from other organisations and see where the gaps are really. And we take that to our communities to see if that's something that they experience, and what their views are about that, and then we would report back on that.
Okay, thanks.
Okay. Jen?
Just to provide assurance, on page 8, Clice refer to the Nursing and Midwifery Council Culture Report. So this is the report nationally into the NMC and their practices and culture and behaviours. I've been leading a piece of work with Sue Tranker on a national basis to look at how we interface and provide support to our registrants within Wales, but within Aneurin Bevan, we've established a very firm relationship with our local NMC representative. We have support with Sarah's team that goes alongside our processes with our registrants, and we provide significant support into the divisions to make sure that there are swift processes, proportionate, fair, swift, and that we support people when they're under the NMC process.
Thank you, that's reassuring. Penny and then Paul.
Thank you. I see, hi Linda, I see that you're doing a mental health and learning disability survey, and I just wondered what the timelines are for this, please, because perhaps it would be interesting if you could come to, when we're up and running, to our committee to discuss it, but I wondered about the timelines, please.
Okay, well, we launched the survey in December, and that's ongoing at the moment. So I understand that it's going to be probably, I think we're holding focus groups during this month. We've already had a few, and then we're visiting inpatient wards beginning next week, I believe. And then we are focusing what's called the Clice local engagement in Blaenau Gwent. So there's a list in the report of the venues that we've visited. They are community centres and the like. And we've spoken to about 165 individuals who have experienced issues around mental health and learning difficulties issues. So I would say probably, certainly by the end of this current financial year, we should be in a position to report on what we've been doing on that.
Great, thank you.
Paul?
Hi Linda, on page 9 of your report, you mentioned about young people, and it said young people find difficulty to get a GP appointment, and there's difficulty to get support. I just wondered, what's the offer from the health board to schools with regard to school nurses, or can something be done in that sort of, is there an opportunity there to inform young people of what they need to do or could it be accessed through the school, or is there an opportunity you missed there?
Sorry, go on.
So we have a school nursing service. It's a really good service actually. We have a really strong professional leadership structure in school nursing. So they've actually done a lot of work in terms of communication with young people. So they have an app and text-based approach because that's what young people find easy to access. They provide lots of support both from a physical and mental health wellbeing, certainly into secondary schools and primary schools. So we do have a really good school nursing service.
So I think, Linda, it would be really good actually, because I thought there was some really good work going on. The use of the app, I don't know whether you're aware of that for children and young people that's been made available.
I'm not personally aware of it, but I can certainly take that back and suggest that we look into that sort of semi-promoting it, if you like, when we meet with young people. Yeah,
that's great.
I'll put you in touch with somebody in the school nursing service so they can give you a brief about the support they provide.
That would be lovely. Thank you very much.
Well done. Thank you.
Any further questions to Linda? No, thank you very much then, Linda, and we enjoy your reports. So keep going.
Thank you. If you could just give Lisa's apologies to the meeting.
I shall, yes. Thank you.
That would be lovely. Thank you very much, everyone.
Thank
Bye.
you. Bye. 6.2 statutory and mandatory training report, Sarah.
Thank you. I'll just cover the report briefly in terms of a summary, as there contains a suite of information there in relation to one of the ways that we monitor the core competencies and skills of our staff around statutory and mandatory training. You see in the paper that it highlights the governance arrangements that we've more recently put in place around statutory and mandatory training with a core learning committee. It also highlights the incremental increase in compliance with statutory and mandatory training over the last couple of years since that arrangement has been in place. We've also had some discussions in the past through People and Culture Committee in terms of the time that it takes to undertake the training, and that's addressed in the paper, specifically around allowances within our rostering for our 24/7 services, and how that can be provided as an opportunity for staff to complete their statutory and mandatory training. However, we will note that not all areas are covered by this uplift, but it is encouraging that when we look at compliance by staff group, areas that don't have such uplift in their working patterns are highly compliant with statutory and mandatory training, for example, health professionals and administrative and clerical staff, to name a couple of examples. The paper also outlines some of the rationale around the 85% target. And whilst we're currently at 81.6%, so still a long way to go to reach that target, we do recognise that we would want to exceed the target and ensure that all of our staff are compliant in terms of the standards and making sure that they have the knowledge and competencies to inform their roles. We've also put in a breakdown by area, and there's a range of compliance within the Health Board, which we will work on. And we've also highlighted some key particular modules that are lower in compliance than others, and we're paying more attention on in terms of increasing the compliance rate around them. They're manual handling training, whole rig disability training, and information governance. Some of you may have noticed that there's a slight difference in our manual handling training compliance. It's 70.14%, and the paper that follows on health and safety is slightly different. That's merely because our report was run in January and health and safety was run in December. But at least it shows progression in the right direction. And then we're also very realistic in terms of recognising some of the barriers that we face on a daily basis in terms of compliance, and to allow staff and enable statutory and mandatory training modules to take place. And we've listed some of those in the paper, alongside some of the work we're going to undertake as a team over the next 12 months in supporting to knock those barriers down and make them a little bit easier to overcome. And very importantly, we have noted in the paper, and it's not a limited list, but it is reference to, depending on job role, depending on professional regulation and registration, the other ways that we support professional development, learning, and ensuring that staff have the skills and competencies to undertake their role safely. And finally, I'd like to give thanks to the Learning and Development team that have completed the report and continue to undertake and drive the work through the core learning committee and with our divisional colleagues. And in particular, if I may, I'd like to pay special tribute to Claire Cullis, who was named but very sadly passed away very unexpectedly early in December. She was certainly instrumental in driving the work, not only with this particular topic, but other topics important to our workforce, and will be very sadly missed by colleagues and friends. Thank you.
Thank you. And we reiterate our sadness about her.
Thank you.
Thank you. Are there any comments? Paul?
Can I just say, I think it's a really, really helpful report, and I think it's it gives us some understanding about, I mean, the total number of hours, for example, non-clinical staff at 12 hours, 30 minutes, and clinical staff 18 hours and 20 minutes. That's the sort of the time frame, 2 days, 3 days, sort of training, etc. And I mean, it does quantify exactly what's required. And I just think that it is very, very helpful to us to understand, you know, what exactly needed to be done. I think this is a paper which summarises and answers all the questions that I wanted to ask on this particular topic. And it's sort of come to us, I think, in a very easy format. So I just wanted to pay tribute really to Sarah and the team for getting this together. And I think the working on some of the barriers then that we can overcome to reduce and get more compliance is the area for development. But on that point of view, I think this is a really useful document for us to understand and realise because I thought there was far more training involved. So actually, the fact that it's been now quantified, I think is really helpful.
Thank you, Prue. Helen?
Again, I do think it's a very helpful report, and I think it's helpful to know how you're vetting, because I know we brought up people and culture, people wanting to add an extra course or an extra bit of training. Just clarification really on in your appendix, you've got the statutory and mandatory, but some of them seem to be very similar, seem to sort of occur twice. So you've got basic life support, and then in the mandatory you've got resuscitation. Are they the same thing, or?
No, they will be different, and not all will apply to all staff groups.
Right.
So there's a differentiation there, whether they're statutory, so everyone has to do them, or whether it's mandatory. And then mandatory could even apply. There's a level of differentiation to what role you undertake within the organisation.
Okay, so they just sounded very similar, but there's obviously different levels or different.
That can be some barriers sometimes, but yeah.
Thank you very much. Thank you.
Penny?
Yeah, I think I've read this right. Staff to be compliant with staff learning as a prerequisite for accessing external training. If that's okay, that seems to be a good idea. Has it helped the uptake? Has it helped,
It's already within our study leave policy, but not one which I think is particularly well observed when study leave is granted. So that's part of the work that we progress moving forward, is making sure people are aware of that and making sure that that is tested. And there'll always be a balance, won't there, in terms of making sure that people have access to external study. But I think bringing that into focus will be another way to help us improve our compliance with statutory and mandatory training.
Thanks.
Paul?
Yeah, just on the point around facility staff having access to emails, so we've done a piece of audit work on this. There's about 1,000 staff who don't have access. So we've now procured the licences for them at the end of last year, and we're currently going through the process of enabling all those accounts for email access as well.
Thank you. That's helpful. David?
I know that a couple of the barriers to the sort of compliance is down to issues with ESR, in particular some of the accessibility issues and general ease of use and regularity of use of ESR. And the NHS Wales Shared Services Partnership are working on a replacement for ESR. Is Shared Services planning on any user research or any activity to ensure that system actually is easy to use, or are they just approaching it as a standard IT software procurement?
So just this week, we've been asked from a variety of angles, myself and Paul and his team included, to start filling out some questionnaires in terms of organisational readiness around the new system. There has been a lot of input in terms of user feedback from corporate functions. Not so much, my understanding is, from frontline staff, but my understanding is that is to be included in part of the development. It was quite eye-opening undertaking the organisational readiness assessment. I think we'll need an internal focus as well as an external focus with shared services.
Thank you. I think there's obviously a big, when we roll out new IT systems, quite often they are not well designed for people and are not easy to use, and a lot of ERP software, which is what ESR really is shocking to put it bluntly, and the industry is particularly bad for providing good user experience. Given how essential it is, we get this training. This training is easy to use. These systems are easy to use. It's really important for shared services. Look at digital and technology best practice from UK government when it comes to rolling these services out, and designing and building this new service, because otherwise we could end up with a system that is just as bad as ESR, if not worse.
Thank you.
Thank you. Paul?
Yeah, just to provide assurance to Davis, we had a presentation at Directors Digital probably about 4 to 6 months ago now. So obviously this work is wider, so NHS England are actually leading on the replacement of the ESR, and obviously working closely with shared services. So they've actually called out user-centred design research as a key component of the development to make sure that the system we replace it with is easy to use and user-friendly.
Okay, any further comments? No? Are you happy then to endorse the actions to improve compliance as outlined in the paper?
Yeah.
Yep, thank you. Thank you. The Health and Safety Annual Report.
Yeah, thank you. I'm presenting this report. Peter Carr's on leave because the change of meeting, he was originally intended to be here last week. And Scott Taylor's on the call as well if there's any particular technical questions that I'm not going to be able to answer. But without going through the report in detail, because it's there to read, I appreciate this is 2023-24 report, which is late in terms of this presentation, I think, and I will commit to make sure the 24-25 report is presented in September at the latest, so that we kind of got an earlier, recognising this is quite out of date now given the progress we made. And in October, I think it was 23, we particularly highlighted this as an area of priority and an area of risk that we've put an improvement plan around. So I just wanted to acknowledge that first of all. I'm just going to draw out one or two and then open it to questions. So RIDO reporting in particular has improved from 22-23, albeit it is still not where we want it to be, and we've got a particular focus with our divisions around making sure we improve our compliance around RIDO reporting. Our manual handling training, recognising we just picked up an element of that in the previous discussion, continues to improve to just under 70%. You can see it's improved in 24-25 as well, but again want it to be higher than 69%, which is where it was at the end of December. It's also worth picking up some of the progress we made on health and safety monitoring and fire risk assessments, with 96% of those completed and reviewed against the blanket areas in 23-24, and 100 we're on target to get that 100% for the end of this financial year. And again, significant improvement on what that was the previous year. And we've managed to secure some funding, so we've replaced some of the fire alarm systems at the Royal Gwent and St Cadoc's Hospital. I just want to pick up, when you go through the report, some of the violence and aggression. The violence towards staff continues to be an area of concern, which, you know, part of that reduction strategy we're working on for implementation 2025 is a key piece of work for us. And you'll also see from the report there's a number of improvements we've undertaken to strengthen the governance processes and the leadership and training around health and safety and policy refresh, which is a key priority for us during this year. So without drawing out any more, they were there, just accept them to formally receive the annual report and the improvements we've continued to make this year, which will be presented in a 24-25 report earlier in January next year. Yeah. Thank you. Paul?
The one thing I haven't seen at all in this report, and I've raised it on various occasions, is the use of body-worn cameras by staff. There's supposed to be some update, I think, by Welsh Government, I'm not quite sure, but I think looking at the great concern about violence and aggression in the workplace and what's going on there, but certainly in terms of supporting our staff as part of a duty of care, evidence gathering wise, a body-worn camera will be so helpful to staff if it comes to somebody who is attacked. Statements have to be provided, and certainly in other capacities I've been present whereby people have denied things, but then as soon as they've seen the CCTV, they've accepted the evidence. So I think it would probably be helpful to know is there a policy in place for Aneurin, Bevan or across Wales? If not, could there be? Could we follow it up? And I think that from probably staff our professional association's point of view, you'll get their feedback and input as well. I think certainly the front part of the organisations where I think the numbers went up, I think in terms of verbal assault, for example, then I think it may be helpful. So it would be at some point to get a report back on that, if that's okay.
Yeah, no, absolutely, and obviously our CCTV plays a key part as well in that where we've got that. But I don't know, Scott, is there anything you want to update in terms of where we're at on that? Otherwise, I'll just make sure we bring back.
Yeah, thank you, Nicola. Just to mention, at the Anti-Violence Collaborative meeting just last week, we were informed that there's a national work stream being led by the Welsh Risk Pool in relation to body-worn cameras. As probably colleagues know, there are some NHS organisations in England who have successfully implemented body-worn cameras within those clinical areas that we're going to kind of take a steer from. So hopefully over the next coming months we should see some developments. Just to mention, we are using body-worn cameras, and as you just said, Nicola, it does come under our CCTV policy in the organisation, but that's primarily used by facilities and specifically security staff, but not by clinicians, which is something that there is an appetite on the front line for people to use because of some of the benefits that Paul just described.
Okay, thank you. Penny?
Yes, I think I've answered the question in my head actually, but I just wondered about in the fire safety report, why so few triannual inspections or assessments of the Grange in comparison to other buildings, except for Ysbyty. So I wondered if it was to do with age. So the age of the building, for instance, the Gwent has got 10 triennials and the Grange has 1.
Scott?
Again, it's just potentially how they fall within the programme that we've got structured for undertaking those fire risk assessments. Some of it might, as you said, be down to age, where we've got isolated buildings that due to their profile would be done on a 3-yearly basis. So yeah, it's probably down to the environment, the infrastructure of those buildings and some of the profiles for etc. what we're using them for and so on.
Okay, thank you.
Ewan?
Yeah, it's a question that really follows on from Penny's piece. I have to say, I think the report is a step forward from where the last report was. But it's still in the position, I think, where it doesn't really give us assurance that we've done what we should have done. So it's how many fire risk assessments should we have done?
What's the no?
Don't know, kind of thing, and I just happened to stop on this page. We did 12 fire exercises across the health board. Well, how many should we have done? It doesn't give me any assurance that we've done what we had to do. And certain elements of health and safety is a tick box exercise. We should know how often we have to do a particular test. So how many have we got to do this year? How many have we done? And I still can't tell from this report where we are. So it gives me no assurance that we are where we need to be with health and safety. And there's nothing, what I keep picking on is Legionnaires, for example. So should we be testing all our water tanks on how many have we done? Where are we with that? And that's the piece. So I get no assurance from this that we're in a good place. We've done a lot of stuff, but is it enough? And where are we missing and all the rest of it? So I don't get assurance from this report.
Can I just check, do you get assurance in some areas? Then there's other areas where that, because you haven't got that kind of...
Yeah, so, I do...
Just clarifying, no assurance from the report, this is no assurance for some areas. Some of it,
certain area, yeah, sorry.
Provides assurance.
So as I say, I just happened to stop on fire drills then, as I was going through it, and we've done 12 fire exercises.
Yeah.
Should we have done 10 and we've done 12? Great, fantastic. Or should we have done 27 and we've only done 12?
Yeah.
I don't know. Kind of thing.
Yeah, and I can pick that up with Peter and take it on board.
I think so.
Because some of it is, there's a compliance, there's a percentage you can provide, but those other areas, as you said, if it doesn't tell you what good looks like, then it's hard to measure.
Exactly, but it was a thing that we raised last time.
I'll make sure that's...
We didn't get that assurance.
Particularly around fire is the main areas. Again, if we, we'll go through the report.
And it is things like, what do we test, and, it's all of that really. It's not a tick box exercise. Health and
Wentworth
safety,
just give it.
but certain elements of it are a tick box exercise.
I was going to say, I added appendix along what Ewan has said would be really helpful, but I have to say I thought the quality of the report was really, really good this time, and I think it's been a considerable improvement, and well done to Scott and the team in its development. So I think probably just the missing link is, as Ewan has suggested, but I just want to say well done to the projection of the report in its format.
Thank you. Any further questions? Helen?
Thank you. I was just seeking clarification. You put about fire evacuation training, aspiration to introduce training to ward areas in 24-25. Has that actually been done, or is it in progress? And maybe, again, looking at the report, yeah, got some information there, but perhaps an improvement plan listed at the end would be helpful to know what your timescale is for next year. But I'm just slightly concerned that evacuation training may not have taken place or for a long while. Seems quite important for clinical areas.
Yeah.
Scott, do you want to respond to that point?
Yeah, thanks, Nicola. So we have progressed with providing more localised evacuation training to our wards and inpatient areas. Unfortunately, there have been some sort of hiccups in relation to releasing staff, because obviously it is very practical, and we may only get 2-3 on a shift. We've tried to target handovers where we can maximise attendance, but again, it's some of those challenges with managing, their priorities on the front line and releasing staff to training, which is what I heard from the previous agenda item. We're working on a training needs analysis for fire safety across all our education. We deliver in that subject for 25-26, which will align to some of the HTM's hospital technical memorandum that's going to be released in the next financial year. But in short, it has progressed, but still doesn't come without its challenges of releasing staff on the front line.
Thank you. Good. Glad to hear there has been some progress. Keep going.
Thank you. Any further questions? No? Are we happy to formally receive this report and note the improvements in compliance?
Yep.
Yep. Thank you. Thank you, Scott.
Thanks, Scott.
Can we move to 6.4 electronic prescribing and medicines administration programme update, Paul?
Thank you, Chair. So this paper provides an update on the implementation of the electronic prescribing and medicines administration programme across the Health Board. Just to remind the board that there's 3 delivery programmes as part of this. So there's the electronic prescription service in primary care, there's a shared medicines record, and then there's the secondary care implementation. And all of this will be supported by development in the NHS Wales app, so patients can have access to their medication record, select their preferred pharmacy, and so forth. So as you remember, the business case for the secondary care implementation was approved last year, and the paper outlines the key benefits which the board was cited on in our development session. I'm now pleased to announce that the contract has now been signed with Better Meds, which allows the Health Board now to progress with our implementation. So we've received funding from Welsh Government for 24-25, and that is now supporting some of the staff recruitment and some of the initial equipment requirements, and we're awaiting confirmation of funding from Welsh Government for 2025-2026. The paper outlines the recruitment that's underway for a variety of clinical and digital roles to support that implementation, and also the roles required to run the service when it enters operation. And we're actually hoping to appoint an SRO next week. We have an informal discussions to move that forward. Some of the current initial risks are highlighted in the paper, so I'll just call a couple of those out. Just firstly, the Welsh Government funding is on our risk register because the Digital Priority Investment Funds ends at the end of March this year. We've had assurances from the Chief Digital Officer that the EPMA is a top priority for NHS Wales and that the funding will be made available, but it's a risk until we actually receive that in writing. And then we're just working closely with Better UK, our supplier, because they've also won the contracts in Betsy Cadwaladr and Hywel Dda. So obviously we're closely working with them and working collaboratively with those health boards to manage the resource ask over the next period. and the detailed planning for the programme is now underway. So just on the wider programme updates, so on the shared medicines record, so this will enable that shared medicines record for every patient in Wales. If a patient goes to a different health board, their medicines record will be available for the clinicians. That is currently undergoing testing, along with some of the migrations for patient allergies and intolerances. As it happens, the shared medicines record is actually being supported by Better UK, so we'll have some good consistency there with our implementation within the health board. And on the electronic prescription service, so there's currently 4 practices live within the Gwent area, so that's Blaenavon Medical Practice, Glanavon Surgery in Tredegar, Greyhill Surgery in Caldicot, and the Village Surgery in Llanbragach. The paper also highlights the further rollout schedule throughout 2025, and each of the go lives takes between 12 and 16 weeks, and there's 18 further practices in Gwent, as you can see in the paper. And our Health Board EPMA team is attending a national advisory group for the electronic prescription service to provide support as required. In addition, 4 of the 7 dispensing suppliers have also had their assurances completed. So in summary, for the electronic prescription service, so 25 out of the 371 practices in Wales are now live, 88 out of the 689 pharmacies are now live, and just over 500,000 items have been dispensed. Happy to take any questions.
Thank you, Paul. Are there any questions to Paul?
Just a small thing, Paul. I just wondered what changes Better Meds was with the contract. Will they be clearer to us? Because it delayed the signing a couple of months. I mean,
yeah, it was
in terms of time or money or anything like that.
It was the financial liabilities basically in the contract, but that we work closely with legal services and the shared services to get to an agreement.
So we're quite happy with that.
Obviously, quite happy now, yeah.
Okay.
Paul, this is part of the primary care service, but are we expecting any delays on that primary care side because of some of the migration aspects of GP systems that's underway?
Yeah, I asked that question actually one of the debrief sessions we had, and yes, because of the in practice position, there is a potential they'll have to reorder some of the rollouts to make sure that they're not implementing EPS and migrating the practice at the same time. So yes.
Anything further? Neil?
Just a quick question, Paul. Is there any early feedback from system users as to how they're finding it and the impact it's having?
Yeah, I haven't seen anything formal, but I have heard that the electronic prescription service in itself is going to make a big difference in how medicines are administered and managed in primary care, reducing a lot of paperwork and time as well. So yeah, I think it's gone down so well in the limited implementations. As we get more formal feedback, I will share that as well. Thank you.
David?
Yeah, I should just note this in effect is us catching up to England. England's had this for quite a long time, and this is us sort of playing catch up. There is an interesting step that we're taking that hasn't been done in England, which is the shared medicine record that will allow us to share the details of primary and secondary care medicines across all of Wales, which is going to be really important. But this is going to most people who have been used to this in England, it'll be catching back up again and having a similar service. It has gone down very well in England. So.
And it helps with the sort of more modernised model that we spoke about earlier.
Yes. Thank you. Any further comments? We're happy to note that report then. I hope it all goes well. The 6.5 Winter Resilience Plan, please.
Thank you, Chair. Colleagues will remember that in November we signed off the winter plan, and in that document they set out the modelling and the intelligence we were using to inform our plan, the actions from a health board perspective, both in primary care and hospital-based care, actions from on the prevention side and also actions in partnership, and then it set out the key metrics that we would use to track track delivery and track impact. So this paper provides an update against that plan. We are unfortunately still in the sort of winter period, and a full report and review will come back to a future board. So the paper is quite detailed in terms of updates against where we are against some of those modelling assumptions, updates against the actions, quantifiably where possible, and also provide, some of which we've heard about already, some updates on some particular challenges that have come our way in winter, which I'll touch on as well. So just in terms of some of the metrics then, the graphs in the front of the paper show that, as we've heard already, in terms of flu, the surge in demand came earlier than we expected and was indeed higher than expected in our worst case scenario. Allied to that, so whilst we outperformed the rest of Wales largely in terms of our vaccination uptake, it was still not at the levels of herd immunity and still lower than previous years. You know, the debrief and post-mortem in terms of lessons learned in terms of starting the vaccination programmes, communications on the programmes, education, etc. That will continue. The graphs and the data also shows that from a bed occupancy perspective, which we track very closely, we have been, bed occupancy, just to be clear, is the number of patients in a bed at midnight. So obviously lots of patients are in and out before the stroke of midnight, but this has been tracking at the upper limit of what was modelled. So that's been quite significant. And pathways of care delays, as the data shows, and we've touched on earlier, have decreased through periods, and we do expect to see some decrease in January from the recent census, but work continues to improve the processes around the collection and clarification of that data and data accuracy alongside the actual actions to improve the processes. You can also see that ED demand has been on the higher side of predictions between October and December, and sickness absence has been high as well. So a combination of all of those factors has led to a really difficult winter for our staff and our system, and ultimately our patients and communities. As set out in the original plan, the governance oversight arrangements have been in place, and the executive team continue to monitor the information I've just summarised on a weekly basis. In terms of progress against the actions, the appendix, or the annexes A and B, give some detail on the health board specific and the partnership actions. Just drawing out a few of those from a health board perspective, there has been an enhancement for the urgent primary care element in terms of mobile support, in terms of work alongside MIUs, all of which to support the admission avoidance alongside CRT, community resource team enhancement and extended hours. We talked previously about the winter ward, which we opened in early January to coincide with where we thought the peak would be. So 23 community beds on the Royal Gwent site. We did open 6 of those early on in a different part of the site in response to the extreme pressures. We've also succeeded in rolling out 7-day therapies at the front door, a straight to STEC model for medical demand, and real-life testing of the operational framework that's been developed to set out the roles, responsibilities, expectations of system performance. We've also enhanced the system leadership over weekends with enhanced senior operational leaders supporting system management. We have still got some more actions to come online, and I'm sure we'll pick these up again in performance report in terms of X3D consultants and the discharge lounge, and some of the actions still in the 50-day plan, which I'll come on to now. In terms of the partnership actions, an update on these went to the RPB on the 14th. Colleagues will recall that partnership actions, we already had a baseline, it's called the System Resilience Plan, that the RPB's been overseeing, but in response to the already referenced 50-day challenge, sort of consolidated against the 10 high impact areas that the CABSET wanted to see progress against. This work has been held and driven by the Integrated Discharge Board that Jenny chairs. I'm sure to come in at some point. Again, a full review to be undertaken, but frequent reporting, oversight, accounting for actions and updates into Welsh Government and the Care Action Committee, but some progress in terms of 7-day working, social workers, expansion in the hospital to healthier home, and support for GPs supporting care home patients. Less progress in one of those areas we're challenged with in Gwent around trusted assessor model, so that work continues to drive that forward. In terms of prevention, the paper sets out the actions in train to respond to the difference and variability in terms of uptake, and also the paper sets out progress from a resourcing perspective in terms of recruitment and the support workforce to the additional capacity. Notwithstanding all of those actions, as was touched on in Nicola's update, it has been a challenging winter, and we were brought to declare a critical incident on the 13th of January, and as Nicola said, stood down on the 20th. The paper sets out the issues that led to that being called and the actions that were put in place to respond. And again, it's been noted already, but huge response from across the system and all partners in response to that incident, and lots of learning to take forward into our operational framework going forward. So a hot debrief has been undertaken, but obviously we'll do a full debrief of that incident to inform future planning. The other bit just to touch on before I pause for anyone else wants to come in or any questions is unplanned for in our modelling was changes to stroke flows in our area. We had a notification from neighbouring Health Board Cwmtaf Morgannwg that they were unable to support acute stroke services in Prince Charles Hospital in Merthyr. We were told in late December, and the change was enacted on the 8th of January. So no acute stroke patients from Powys, North Blaen y Gwent and North Caerphilly. They used to go to Prince Charles. They were then redirected into the GUH. So we are working with our ambulance colleagues and CCM colleagues to really understand the impact of that flow. The early modelling suggested 100 a year, so 2 a week. We have seen high stroke demand into our system, but understanding what's driving that. Is it the changes in local provision or is it seasonal? We need to do a bit more deep work on that, but that is something we hadn't planned for, and operationally, clinical and operational leads had to sort of very dynamically change pathways and focus on receiving that additionality. So that's something, as I said, we didn't plan for. There will be a lot to learn when we fully completed the plan, both locally, I think also nationally, in terms of the modelling and approach. And one of the things we've definitely picked up is the need to start our detailed planning earlier locally. So I'll pause there. I don't know whether anybody, obviously Leanne's intimately involved as is Jenny on the 50-day, but take any additional comments or questions.
I think it's pretty comprehensive, and we've referred to it via next update as well. So I think
I'm quite happy.
Any questions? Any?
Can I just ask that the high sick rates amongst the staff, could that be to do with the low uptake of vaccinations, flu vax, amongst the staff?
There definitely was an increase in cold flu viruses in terms of absence. It's difficult to correlate that with the uptake of the vaccine. And the most significant rise for reason of absence we had was actually down to gastro infection. So it's not a straightforward picture, Benny, but I'm sure there is a part to play there, but it's not directly linked in terms of our data. But yeah, that'll definitely be something to address next year.
Thanks.
Paul?
Could I ask what's the issue with the trusted assessor?
Oh God!
Because that's such a fundamental sort of area, and is there anything more we need to do, or can any advice or any good practice from anywhere else can be utilised? Because I think that would make a significant difference.
Would you like to pick that one up, Jenny?
Yes.
That's a nice one to answer.
Across Wales, there are different models of trusted assessor. I think that's fair to say. We have two areas where we do have a trusted assessor model. One is YYF stroke pathway, and the other is an OT in-reach that we have at YAB. So there are examples. Effectively, a trusted assessor model means that you are trusting somebody else to do the assessment for you. Part of the reticence has been, the conversation with the local authorities are focused around the fact that they feel we have alternative models which are better than some of the best exemplars in Wales. But effectively, it does mean one local authority committing resources on behalf of the other, or potentially health staff committing resources on behalf of the other. So there is a reticence. I think it's fair to say that it's well known in Welsh Government. I think the Minister is aware of the difference in Gwent and the reasons why. So it's not, I was quite candid at the Care Action Committee this week, and I think he was aware anyway of the concerns. What we've got them to do is to commit to a review against national best practice. That is due to be completed by the end of February. And I think what we will need to do is probably escalate the findings of that review through the local authorities and probably to Nicola's level, because I think we are, with 5, we're unlikely to reach an agreement. I have said to them, if they won't agree to health assessments contributing to social care commitments, would they do that on behalf of each other? Because that's part of the reason we have delays in some parts of the systems. They're still reticent about that, and they do have 5 different ways of doing things. So there are different referral pathways, different ways in which they agree funding. But I do think it's one of the issues we have to get underneath and behind. And to be fair, I think the Minister will be testing the RPB on that.
Yeah, we were tested last week.
Because at the end of the day, the focus should be on what's best for the individual or patient, and that should be the focus rather than looking at empire building or sort of looking at territorial areas. So I think actually there's probably, again, I think the Minister's probably going to open the door there to, there's a problem, let's look for a solution. There's a challenge, there's an opportunity, and I'm hoping that perhaps this, because it would make a difference in terms of the support. So
I do think the discharge to risk assessment, so some of the work we've done around pulling people home to do the assessments, there was reticence to that and to that increasing dependency and need. That's not correlated. We've got the formal evaluations to come, but the data doesn't suggest that pulling patients with health support into a care home or their own home increases dependency. So that, we're able to use some of the evidence we've gathered, I think, through the winter to really test against that.
That's encouraging because we've got a bit of an action plan. Thank you.
Thank you. Leanne?
Sorry, just very quickly on the back of that, I think there is an element of, I've seen Jen sort of have some of the conversations in the meetings and had a very strong response back around professional disrespect through a trusted assessor model. So there is quite a lot of heat, I think, out in the system in terms of views, which means that it's pretty contentious. So I think one of the things we've tried to do is take a little bit of control for ourselves around around how we can influence this, and obviously flip it around the outcome we want. The outcome we want is no delays in terms of our patients progressing to wherever they need to be in the system. So we're doing and finalising a piece of work at the minute around our escalation process with our local authority partners. I think there's been a sea change instead of dealing with them on a 5 basis, when we deal with them on an individual basis around particular issues, and they have engaged, I think, better on that. So we're agreeing levels of escalation at different levels. I think that means, in theory, if they engage with it, I think if they don't, that's a separate issue, but they should. I think they have, with the initial individual local authority escalation, should deliver the same outcome for us. Yes. And that we've got some working standards in terms of how long we would expect those assessments to be undertaken, that in theory, as I said, delivers the same outcome. So we are not just waiting for the outcome of the trusted assessor, but trying to take and build it into our operating framework as well, so that our teams know what to expect and when to escalate.
Good.
Yeah. Rob?
Yeah, just to pick up as well in terms of, because it won't be in the finance report, because the finance report is month 8. We've just completed month 9, and there's a potential cost of the additional beds we've had to open through surge beds in of as much as £400,000 that is costs that aren't funded. We would be looking for mitigation through our PPE mechanisms and obviously managing wherever we can down ourselves. So we've had a little bit of a spoiler. We are holding the forecast financially, but that's through assumed mitigation. So just to make that clear that the pressures on the system go beyond everything that's been done so far.
Sorry, could I just add, just on the back of what Leanne said, the other thing we're about to do, so we've just launched the Optimal Ward Framework. It's a national piece of work. We're doing that with Gwent on 4 wards. We have got some agreement with them to have greater social care input, and the standards Leanne has said we're going to test through that framework. So we'll almost be able to test it live as we put into place some standards around what our expectations are for management of patients who are delayed or medically optimised.
Thank you. Any further questions? Yep.
Yeah, interesting. I was going to ask about the bed question, and Rob has answered it really, because one of our key planks in the IMTP was a reduction in beds, wasn't it? Really? And of course, what we've done, partly because of winter, is open more beds, which is not being shown on anybody's balance sheet other than ours, probably. I would have thought that pressure would be very well recognised within the RPP, because people would think, well, if people are in a bed, then it's down to the health service. So I think that's going to be a hard one. And I guess, what do we do with the beds? It's difficult once you've got them to take them down, isn't it? Although maybe we'll have to be thinking, especially in taking them down, but it's not going to be easy. And it's certainly not going to help the discussions anywhere. And it would be interesting when you're looking at the figures now, if we took the extra beds out of the figures, of course the figures would look much worse. They're looking not brilliant, but reasonable at the minute probably, because we've got the extra beds, I guess. And then the other thing that I think that doesn't come through the report is how hard are we really pushing the 7-day working issue? Because it seems ludicrous that we have most of the system working 7 days, but the social care system not. And if you look at the figures around the Christmas kind of hemorrhaging of numbers, well, there were at least 80 extra people in a delayed transfer position over that period, because most of our partners shut down for almost 2 weeks. So I think in preparation for next winter, that's something we need to keep right in the middle of the discussion, is how do we really introduce a 7-day system, but not just about, well, asking people whether they're prepared to do the odd Saturday morning, which is I think what we're asking now, what is being asked. And I think we need to say that social care needs to change. It has to become a 7-day system. So people have to get into the system of maybe working a Saturday or a Sunday and then having a Wednesday off. I mean, that's going to be a difficult one, but I can't see how we can sustain the business that we are trying to sustain when a bit of it just stops. Stops every week for 2 days, doesn't it? And then it stops at Christmas. It'll stop for a week at Easter, which is coming up. I really think that's going to be one of the key areas that we try and work on. And in terms of the trusted assessor, of course, that was a recommendation of the commission that looked into the future of the social care in Wales that reported over 10 years ago, is that they introduced a trusted assessor and a portability of assessment system, whereas if a person has an assessment in one part of Wales, they could carry that to another part of Wales or start their services without another assessment. Those 2 bits have never been enacted. But it was accepted in its entirety by Welsh Government 10 years ago. So it's taken us 10 years again to get to this stage where we still can't seem to deliver it. But really, it's interesting reading the report, looking at all the work that's going on. I mean, at times it reads a bit like a bit of a war journal, doesn't it? And it probably feels like a bit of a war journal if you're trying to work it. But there's clearly an awful lot of work going on. I think what this winter has done for me is to burst this bubble of people constantly saying, well, we don't think about winter because actually we're busy all the time. And I made that point at the recent RPB. The numbers of people who've said to me, well, we don't think about winter because we're busy all the time. This is part of a normal day. Well, actually, the winter's hit us this year. So we do need to think about winter, and we do need, across the system, to think of the different areas. But I know you all know that, I think.
Yeah, just 2 points. So one, the evidence says more people die of respiratory illness in the winter. So absolutely, I've got it. It's just doesn't recover too much as we'd like it to. I think just the only other point is, you know, we've had this reflection, I've spoken to 1 or 2 local authority chief execs, is, you know, how do we achieve such a mass reduction? You know, Rihanna always refers to as the miracle of Christmas, before Christmas. You know, Christmas Eve, we had 85 empty beds, some of that would be surgical, but 85 extra beds. We did a massive, anyone who could get home, we got home, everybody pushed there, and then, yeah, it built up over the 2 weeks when there was the close down. But, you know, and I've had a couple of staff when I've walked around, I've been out and about quite a bit saying, how can we achieve that last week? And now we're back to where we are this week. And we've got all of us hold a mirror up to think, how do we systemize some of that work into every week, you know, every week's Christmas, you know, because, you know, it's obviously achievable with the right effort, isn't it? So what would it take to achieve that on a regular basis? And I think, you know, we can't lose that reflection as we head into March, April, now we forget about when we come next December. Let's keep looking back. What did we do? You know, even during the critical incident and the escalation, we received, the graphs show that we received a higher level of discharges that week when we put a different focus on it. So why can't we do that routinely and get people out of hospital appropriately? So I think we really got to not lose sight of that as part of the work we do, I think.
Any more? No. Thank you. Thank you very much, Hannah. And I think it'd be really good in the July meeting if you could actually outline what really worked for us that we'd never done before. Because many of these schemes we have done before. So what was new? What was the creative thinking? Thank you. Performance report, Anna.
Okay. Yeah, no, thank you, Chair. So this is the first of the suite of reports under this agenda item, integrated report. It was because of like the timing of this meeting, and then we weren't going to have had the quarter 3, sorry, full information. But when it was moved back a week, we have snuck in as many December metrics as we could. So we will build on updating against the annual plan commitments as we normally do in the quarter report for the next report. Just a detailed report, just want to draw out a few key areas. We've talked a lot about vaccination in the context of the winter viruses, respiratory viruses. We did have a detailed vaccination report at the committee yesterday that Tracy presented, but just to highlight that, so vaccinations in the under 5s has been steady, but below our ambition and not where we want it to be. And similarly, HPV rates, which we talked about a lot yesterday, are not where they need to be, with actions now put in place across the primary care and school nursing teams to try and recover that position. Baby checks continue to do well, which is a really important intervention and an indication to support that best start in life. It's not quite where we need it to be. In terms of cancer, this is a really positive story so whilst our PTL remains sort of around the same sort of size, our PTL is the number of patients we are tracking through their cancer pathway. Performance against the standard improved. From the last report you received would have been 57.1% in September. That increased to 62.4% in October and 63.7% in November. We await December's once validation closes at the end of the month. So really good incremental and sustained progress there, but still further work to do to achieve the standards. Similarly, the backlog for patients has been a huge focus by the clinical and operational cancer teams on improving those waiting on that pathway for over 62 days. Just to remind colleagues, this was at 475 in May, and that's down to 260 in December. And similar improvements for those over 104 days on the pathway, from 150 down to 62 now in November. What I did want to call out, and is quite pertinent after that sort of very impactful patient story, was the good progress made in maintaining performance against the decision to treat. So this is within the standard is within 28 days, you know your diagnosis in terms of do you stay on the cancer pathway or do you not have cancer, which is a really important patient experience metric. And I think some of that stuff was played out by the gentleman sharing his story earlier. So really good that this is at 85% consistently now and through the teams. And all of that work has been through the work of the task and finish groups, the tumour site task and finish groups that are clinically and operationally led from the ANS team, and also the work of the cancer services team. We've really tightened up just the process by which patients are being tracked through the system. Nicholas touched on planned care already. We need to note that we have now achieved our ambition of having 0 patients waiting over 156 weeks. That was achieved in December after just 1 popping up in the last couple of months. And again, that's been a huge effort, not just to get there, but to sustain as well as we go forward. 104-week waits is a significant focus at national level, so it's a significant focus for us as well. We'll know from the paper received at the last board that we've had additional monies to support improvement in the position we've set out in our plan. So there is a wealth of activity within the teams to bring online schemes to respond to that money, particularly in the area of ophthalmology, both cataracts, which we're doing regionally, but non-cataracts as well, orthopaedics, and ENT. And so the expectation nationally is that we are delivering a 0 position. There are risks within that with the bringing online of all of the relevant schemes, and we are tracking those risks and very closely as an exec team, obviously keeping Welsh Government informed of how those risks are materialising or not. 8 weeks position for diagnosis continues in a positive position with some additional support through monies in endoscopy. We do have a challenge, as we do across Wales, in terms of the neurophys component of those weights. So just to note that. Nick has already trailed the huge improvements and successes in adult mental health. We've been promising improvements in that for a while due to the work of the teams on, we've talked about process improvements, the benefits of RPA, and then good management as well as pathway redesign. So as of December for adults, the 1A, so 28 days assessment, is at 90%, and 1B is going to see shoot up from what's in the report up to 87.8%. So huge progress there. The teams now recognise focus on the psychological weights and bring the learning and approaches from the Part 1A and Part B. And CAMS, again, 1A has been consistently performing, but now 1B, as Nicola reported, the December position will be 84.7%, which is compared to the 14.7% in November. So huge efforts from the teams, and that was noted in the recent Welsh Government performance meeting as well. Yeah. Urgent emergency care, I think we've covered quite a lot of detail in terms of winter. We remain in enhanced monitoring, remain the weekly exec-led review of the actions in place, and also regular updates with Welsh Government on this. But because of the challenging position we've been in, you'll see our metrics against the ambulance handovers, the waits to be seen, continue to be challenging. So the actions, they really similar to the ones set out in the winter plan, and those to come online around ED consultant growth, the new ED extension waiting room, which will give physical capacity as well, and the discharge lounge, and not least the embedding of the operational framework. So quite a lot of information there, but I'm happy to take questions or other colleagues will, I'm sure. Thank you.
Thank you, Hannah. Are there any questions, Paul?
Could I ask about on page 248, on the right-hand side, about occupational health? So that seems to have really gone timeframes. Looking at 2 months to get to see a physician, and then 2 months. I mean, we look at the timeframes there; they all appear to be obviously an issue. I mean, what are the numbers of referrals to occupational health, and what's been the problem?
I think Sarah's going to do that. I'll take that. Thanks, Paul. I've asked for a particular deep dive in terms of OC health against the demand and capacity that we've got. We have lost a couple of team members recently, some for retirement, some moved on elsewhere. And also due to the shortages of occupational health clinicians across the UK, we have been relying on an outsourcing position for significant period of time. We have taken the opportunity to increase that outsourcing supply over the winter period, and that has helped to reduce our waiting times by 2 weeks, but they're still significantly long, I would agree, hence my request for the deep dive. And just to note, only a small proportion of staff will actually need to see a physician.
Right.
Most will be dealt with by an occupational health nurse, and it doesn't impact our onboarding timescales either.
What the numbers were for?
I haven't got them off the top of my head, that's what I'll ask for the deep dive, but I'm happy to share that, and also
People and Culture
to
Committee.
bring it, that's what I was
Yeah,
just going to say, bring it back through.
Yeah, thank you for that.
Alan?
Thanks, Hannah. I'm glad to see there's obviously been quite a lot of progress in some areas. I just wondered, obviously, with the pressures on planned care, with having to declare a critical incident, has that had an impact, i.e. that you've had to use, beds on surgical specialties to accommodate the...
I'm sure Jan will come in, but a very good example is the cath lab. We've been putting patients just in the run to the critical incident in the cath lab, which in terms of the 8 weeks diagnostics was certainly hit. That's a very obvious sort of impact. Teams are doing what they can to recover that, but there's, in terms of loss of activity, hand up.
So during the critical incident, we tried to put as many senior decision makers at the front door, which meant that they were moved from elective activity to support the Helen.
That's another way of, not just the beds then.
No, so we did lose capacity. The beds is a bit of an issue for us because we don't have the medical doctors to look after the patients. And the surgeons, as you know, can't really look after those medical patients. So we do have, and because our sites are split in terms of the Grange is our hot site, and then sort of the Gwent in the main is our elective site, we have been able, I think, to be quite successful in sort of maintaining the integrity of that pathway, because often they impact, don't they? Like you'll know, lap goalies that don't get done on the waiting list for present front door. So there is a really fine balance, but we did lose elective capacity. We will do that in the debrief. I think in terms of some of the points that Nicola's raised already about what we've done during both critical incident and industrial action is have a senior decision maker, given some primacy to urgent emergency care. And I do think we are going to have to grasp that network and then come up with a sustainable plan around what that looks like going forward, so we don't just deploy it in, they are the times that we have seen empty EDs and waiting rooms, because in part because of how junior I think our resident doctors are now, but also the benefit of the speed of process as well. So it has had an impact, not a huge one, fortunately, but obviously we've captured that and quantified it.
Yeah, so it's interesting, it's not just the beds, it's actually the staff that you're actually having to move out. So it's not as though they could get on. Certainly the olden days, they were very integrated, and we always had to stop for January and February on elective operating.
And to be fair, the surgical division gave up the surgical resident doctors, as they're called now, got to keep reminding myself, for the first couple of weeks of sort of the extreme pressures to support the additional medical patients on the wards, just in terms of sort of routine tasks.
Everybody faces it. Yeah.
Thank you. Any further questions? No, thank you very much. Quality outcomes. Jan.
Thank you. And I will take most of the report as read, but just a few areas to highlight. Clearly this meets our duty of quality around always on reporting. As you know, we report around our 6 pillars of quality, and we also report another of additional metrics which go to either patient safety, patient experience, or clinical effectiveness. This is a report in mid-development, so we've been working with some external advice on the structure and process of the report. I've got a further iteration to go through with Nicola, so we will see this report continue to evolve. But as you know, we were the first organisation in Wales to move to a quality outcomes framework. So there's further work to be done on structure and process, but we've moved significantly forward, I think, in the way we report quality to meet the duties. So just some areas of improvement to note, some areas for focus really. for us. So it's been really pleasing, I think, in this quarter to again see that we've had 86% positive emotional responses. So that's where people have responded to say emotionally that they feel supported within our services. So that's really pleasing, and we remain above the 85% benchmark for our patient staff experience. We have had a delay with the text option coming in due to some technical issues, but we'd anticipate that going live in February or March. Safeguarding training compliance has improved for level 1, so it's up to 87% for adults and 85% for children, so a real improvement in terms of our baseline basic safeguarding training compliance. That's really important because safeguarding level 1 is really there for awareness raising, and that means if people are aware, they're more likely to report. And you will know we've reported previously that our rates of reporting of safeguarding issues has gone up. So whilst that poses a difficulty for my team in terms of capacity, it's absolutely the right thing to do to make sure we're getting those cases alerted to us. I'm really pleased to say that James and Leanne, supported by myself and Peter, have launched a programme around sepsis management. That's really on the back of some of the work that's happened around deteriorating patient, and the board will have heard previously around some of the examples of best practice we've been building around how we identify patients who are deteriorating and intervene early. You'll remember that we've talked previously about Martha's Law. So Martha was a child who died in England, and that process is about people being able to ask for a second opinion or a review based on their view of how their family member or they're feeling. So we've embraced that. That's part. It's called Call for Concern in Wales. And that's part of the sepsis programme as well. So we've looked at all of our comms materials. We've held an improvement workshop. So lots of work ongoing around increasing awareness around sepsis. And the final bit to highlight, two other brief bits to highlight in terms of improvement. I'm really pleased to say our ward accreditation, team accreditation programme is going really well. We've reviewed 14 wards. We focused wards first. We will go into teams phase 2 and 3. We've got 8 that have achieved bronze, 6 have required further reassessment, and I was pleased to give a number of certificates over the Christmas period. It really does give a sense of well-being, pride to the team. So there's a little bit of competitiveness out there now for silver. So I'm hoping we will get to our first silver award in due course. So really pleased that everybody's got behind that. We've had medical staff, therapy staff, domestic staff involved in this celebration event. So it's been brilliant to see teams come together around both understanding their data and the improvements they need to make, but also celebrating the fact that they've achieved a benchmark. So I think that's been absolutely fantastic. And we've managed to, you'll know I reported previously that we were outside of the Welsh benchmark for closure of nationally reportable incidents and timescales. We've improved significantly over the period, and I think we're now at 33% overdue. So that's down from 33% overdue. That's right, with most in compliance. Benchmark is 70%, so we're nearly there. So areas of focus for Q3, incident reporting. So just to highlight to the board, and Peter will be doing some focus work on this. So although 99% of our falls result in no or low harm, there's an ongoing upward trend in falls. So we do know that whilst most of them are low harm, the trend is upwards with the reporting. We have seen a slight increase in non-moderate harm incidents as well in medicines, and we're going to be doing further analysis and action in those areas. In terms of falls, Peter and his team have done a piece of work looking at what will make a difference in terms of reducing the numbers of falls and the levels of harm. So we've included a slide within the pack on the actions we'll be taking forward over the next quarter. Disappointingly, our complaints performance continues to be about 55%. We've made real progress on our over 12-month delays. We're down to 4. I signed another one off ready to go to Nicola this week. So we'll be down to 3, and we're obviously keeping an eye on the ones that are in that 9 to 12-month bracket.
we have done really well. Our early resolution performance is around 67 to 76%. I think it was 76% in the last month of the quarter, but we are teetering just under the 70% in general for early resolution performance. Further work to do on our complaints, but we've discovered that actually we're probably over-reporting. So most health boards will report in-month compliance. We report total compliance. So we're going to start to try and split that data out so it's clearer to see where we are in month, because we actually do really well in month. But some of our aged complaints draw down the performance, which we will correct. Themes continue to be the similar around clinical treatment, clinical care and treatment, communication, attitude and behaviour are the main issues. And finally, just around areas of focus, you'll know that our infection rates have risen. We've seen rises in C. difficile, Staph aureus and Pseudomonas. We have an enhanced oversight arrangement which James and I jointly chair. The winter's obviously been a really challenging period for us with outbreaks, a number of outbreaks of infection across COVID, flu and RSV. We've seen a rise this winter, more so than last winter, in terms of norovirus as well, so gastrointestinal infections as well. Conversely, that's actually had a positive impact on our C. difficile rate. So we have seen a reduction in December, January for C. difficile, but of course that's due to the measures in place. Those measures won't remain in place forever. So we've put in place a number of key actions. We're really focused on antimicrobial stewardship, given a very detailed update to PQSO on that, and we continue to monitor our rates and really focus on the basics of infection control. Mask wearing where it's designated, hand washing, cleaning standards, so the basics, because I think that's the key really, is getting back to some of the basics. So I'll pause there on for any questions.
Thank you, Jen. Any questions for Jennifer about that? It's good to see progress being made, and it's quite clear where the areas of concern still remain. It's really helpful, and thank you very much.
Thank you.
Thank you. Finance.
Thanks, Anne. So the report included today is the 8-month period ending 30th November 2024. Some highlights of the report. So the revenue position is reported as year-to-date deficit of 6.6 million with a forecast of 7.3 million deficit. I'll come on to that and talk through that in a bit more in a moment. Our capital position is reporting a break-even forecast, and we're well on the way to spending the allocation of £65 million. Our public sector payment performance has improved above the 95% level that we are required to, and we're hitting 97%. And cash holding at the end of the period was 3.3 million, which is within the £6 million cash holding set by the Welsh Government. So our forecast was previously reported as 47.8 million, which is a £1 million improvement on our original plan. In December, we received a letter from Welsh Government which indicated they were going to give us recurrent funding of 40.5 million. Now, 40.5 million is split between 9.5 million, which is our adjustment for fair shares for Aneurin Bevan, and it was an adjustment that was done for all health boards. We also received, unique to Aneurin Bevan, £31 million, which recognised Aneurin Bevan's specific cost pressures, particularly around GOH, drugs and CHC. There are other unique allocations given out across Wales, but they are different and they're not for the same thing. So that 31 million is quite a coup for Aneurin Bevan. However, the £31 million is conditional, and it's conditional on a range of objectives being achieved. The main ones being that we achieve our 24-25 forecast, which if you take our starting point of 47 and take the 40 million off, we're down to 7.3 million. So we have adjusted and we are confident in delivering a 7.3 million pound deficit. The more challenging aspects are they are also expecting us to present a balanced financial plan for the next 3-year IMTP period. and developing sustainable plans to achieve 104 weeks waiting times going forward. A couple of other points around expecting us to leverage and deliver the benefits from Clinical Futures GOH investments, work regionally and progress the regional agenda, and agree all intra-NHS contracts, long-term agreements, ready for the new financial year. So there are a few stretch targets there for us in terms of those conditions, but for this year, we are confident of achieving our financial target of £7.3 million deficit. If we can do better than that, they would like us to, and obviously we're aiming to do better if we can. Our position also assumes that we will receive funding for all wage awards fully, and we're waiting for that to be confirmed and finalised by Welsh Government currently. The other thing that I would draw to attention, which we just touched on, is that we have had £14 million waiting times funding come through in Q3 to deliver 104 weeks as a longest waiting time for all our services. £7.5 million of that is for local ABUHB pressures, and £6.5 million is for regional cataract services, of which we obviously benefit from that as well. But we are the manager, if you like, and the banker for the regional funding for that programme. So that gives you a sense of the amount of money we've had non-recurringly. Sorry, I should have said the £40 million is recurrent, subject to the conditions. But £14 million is non-recurrent in terms of additional funding that's come through to the bust waiting times. Leanne has alluded previously to the pressure on the system and our aims to deliver that. That hasn't been reflected in any favourable impact on our financial position, because if we don't spend the money, the directive is it will be recovered. We have, however, been allowed recently to flex some of our plans to make sure we try and optimise the availability of that funding across a wide range of services, not just the ones we bid for. So that's a positive for us to go further where we can. So that's really the big news in terms of the reporting for month 8. In terms of the operational position, so in month 8 we spent £92 million on pay, which is £26 million increase on the previous month. However, £25 million of that, or just over, is for back pay wage awards that were eventually settled and agreed and paid. So our pay run rates are broadly the same. Variable pay did shift from agency reducing to bank increasing, and some overtime payments. So again, from a pay perspective, our run rate is stable. Non-pay increased by £3 million, most significantly for areas that were funded as national agreements, either through the pharmacy contract or through specialist services uplifts. So the key message for non-pay I would give is that drugs continue to be a pressure for us. That's reflected in the report. We were able to hold the forecast, though, because of other mitigations and savings identified. In terms of the savings position, the plan was 40.5 million. Our forecast is 43.2 million, so we're overachieving against our target there of 2.7 million. Of that 43 million, 42.6 is ranked as green, 0.6 as amber. So again, the confidence in delivery for Q4 is significant, and close to 25 million reported as delivered to date. The report includes a reflection of some of our operational pressures. Delayed transfers of care continue at similar levels. CHC cases have increased by 14 cases, and I've mentioned drugs and prescribing, and that's reflected in the forecast. In terms of just a quick update for month 9, because the paper timetable didn't allow that to be prepared. Largely the position's the same. We're holding the £7.3 million forecast deficit. Winter costs have been factored in, as have continued creep in some of the drug spend areas. That's been mitigated by additional savings and a deferment of some of our corporate spend for Q4. So overall, the big message is being confident of delivering the £7.3 million deficit forecast, which is our revised control total, noting the new funding we've received, both recurrently and for RTT. Thank you.
Thank you, Rob. Are there any questions to Rob on this? That was quite clear, and thanks to everybody for trying to hold this financial position, which is not easy, given the stretch and the pressures on us, and particularly when we get on to next year. I think this year has shown us we can do it, and I think that it's been pleasing to note, difficult but pleasing, that both for waiting times and for money, we have said we will deliver X, and that's what we've delivered, and we haven't had to move, which is, at least allows Welsh Government to have confidence in the way in which we've tried to look at what can be achieved reasonably. So I think that's good. But thank goodness it's not 40 million we still have to save on top. Yeah. Okay, on to next year then.
So in terms of the allocation letter we've received, the report is a summary of what is the usual very complicated WHC that we receive. Hopefully it's laid out in a way that's understandable. So Welsh Government issued Health Board allocation letters for 25-26 out on the 20th of December. It's reflective of the financial year 25-26 uplift and new monies available. It's based on funding unavoidable demand growth and inflationary pressures from Welsh Government assessment of what they feel health boards should be able to operate within. From a 25-26 baseline funding position, we've had an increase of £126.8 million. That's 1.77% increase on our baseline as at December 23. So it's a reflection of last year's or this current year's original allocation figures uplifted to take us to the new year. As a result of that, any new 23-24 in-year funding that we receive currently, that's added in and included as part of that 126.8 million. What it effectively means for us is the new funding we've had that's brand new is 27.7 million. Just over 25 million that is on core funding and 2.5 million on mental health funding. And the tables draw that out quite clearly, I think. One thing to note is a directive that as an NHS commissioning organisation, we are obliged to pass through to other NHS providers 1.77%, and that's an estimate of about £7 million impact for us. So after estimating that, our new funding to determine to manage cost pressures for next year in any developments is 19.9 million. The other thing to note is we've discussed previously about allocation shares and what's our fair formula share, and we have moved from just under 17% to 18.65%. So we are moving towards, from an AB perspective, we are moving closer to a target of fair shares formula target of 18.9%. And obviously that's been influenced by the funding we've had, where the 31 is exceptional to us. Things to note then, that the allocation letter does not include pay awards, but the intention is they will be fully funded. And it doesn't include primary care contract uplifts because they're not negotiated and agreed yet, but again, the intention is they will be fully funded. We've assumed, because the allocations include it, the conditional funding will be available to us, which is the £31 million, which I've just mentioned came through in December, but also from 23-24, the £64 million that was received conditionally. We've included anticipated allocations of 59 million where there is a Welsh Government policy letter indicating that we will get that outside of the core allocation process. So overall, the additional funding that we've got for new services, the key message is around about £20 million for next year. So it's not a lot of money in the context of general uplifts, but as a health board we have had that £31 million to note that. And boards has to note the report.
Thank you. Any questions?
Sorry, Rob, just on top of that then, so given the additional funding that we're likely to get, what figure of savings do we have to find next year?
So we're expected to find 2% savings, which is of the order off the top of my head of about £35 million, £36 million. But as we work through our annual plan and all the rest of it, our actual requirement will emerge from that.
Okay. Right. Well, we look forward to receiving the next report on how we're going to manage within these resources. And we've got, or we, Wales, not we, have got a number of regrading claims nationally at the moment. Are they anticipating funding those if successful?
I'm not sure we have any clarity on that at this point, given the nature and the dynamic position we find ourselves in.
Right. A cautious answer.
It is.
Right. Okay. Fine. Can we move? Sorry.
Yeah, just to one thing. So one thing Rob's working on with the team as we progress into the plan cycle is trying to keep that kind of line back to the 3-year roadmap that we produced.
Yeah.
In terms of what would that say, and recognising what would that mean then with additional funding, and then if it varies, why it varies. So we've been quite, diligent in terms of keeping our line of sight back to different, that we know why. So, and I think as Rob mentioned, that when you read the monthly report, the size of the increase in prescribing and secondary care drugs is kind of off the scale really, in terms of, it's quite incredible we've managed to absorb that. It's in the region of £13 million this year. There'll be a full year effect of that. So that feels like one of the most significant challenges we face in amongst everything else. So, but Rob's obviously keeping that kind of close eye on the roadmap versus where we end up.
Thank you. Could we go to 6.8, the strategic risk report, please?
Very briefly, I won't go through it in detail. We enacted the changes that we approved last meeting, and following the committees, there's 2 proposed changes. One is reducing the risk score of the workforce risk that we've identified on some of the progress we've made around recruitment and turnover, suggesting that's reduced from a score of 16 down to a risk score of 12, just in terms of the likelihood going from likely to possible. And then the other change is introducing a new risk which was picked up on, we decided to add around the Welsh Government's decarbonisation targets, where there's an expectation of us being zero by 2030. So to reduce by 30% by 2030. So due to the risk of that, we've added that in with a risk score 15. So not going through in detail, they are the 2 changes in risk. So to maintain the others, those 2 changes is what's recommended in the report.
Any questions or comments? Ewan?
Yeah, I guess it ties in this bit to the next bit, the nursing bit as well. It might just be a comment or a question, but obviously Cardiff Uni's kind of announcement yesterday, they're going to close the nursing college, nursing school, nursing, whatever we call it. That could have a huge impact going forward.
Absolutely. Yeah.
Absolutely. As much as they were on about on the news yesterday, it's going to impact, Cardiff. But it's going to impact everybody.
60% of our film.
Yeah. And they haven't given us notice either.
I haven't given anybody notice, have they, or something like that?
No, it's very odd how it's been done. but it appears to be quite firm because they've already emailed my education lead saying that they'll be running no nursing, no, not even postgraduate courses going forward. So it is a real blow.
Yes.
HIW are linking in directly with the university because obviously Jenny and I have been emailing back and forth. We do have contractual arrangements through HIW with the university in terms of delivery, and also noting that it is a source of guaranteed income for the university, albeit they express difficulties with international recruits. We do provide that, so we'll stay close. I know Jenny will stay close to it, and we'll stay close to HIW as well. There could actually be a significant impact to us, especially when our line of sight at the moment shows that we will be in a really good position, almost eradicating our reported registered nurses vacancies in September. If all goes to plan, I will caveat that. But there will be pockets which will be different, but it will impact our long-term position.
So having just reduced this risk, bunging you back in again.
Maybe.
Right. Yeah. Well, I think we'll have to have further discussions with them to understand precisely what the impact is. But it is a guaranteed source of income. It seems to be an extraordinary decision.
What level of British versus overseas students do they have?
I don't know about
I'm not sure
because they're blaming the drop in international students
I
as being the risk, but I'd have thought.
But what we do know is that they don't fill all their places from local recruitment, and there is a slowing down of people choosing to undertake that educational course, and when they do, attrition rates are high. So we know that, and I know HIW have been doing a lot of work around that. It is positive that we've got flexible routes to work in. We've got the RNA role coming up. So there are opportunities as well to wrap around this, but it is significant, and we do need to understand.
And it is about working with the other providers.
Yes,
the other providers of training in the area to support them.
And making sure we support our students. So Jenny's hot on it.
We picked up how to support the existing students who will obviously be nervous.
Yes.
We also have a number of nurses going through master's programmes, particularly in advanced practice through Cardiff Uni.
Yeah, I understood that they were going to honour existing. That's the general message that's gone out.
But if a uni's going like that, it's how we support them during that period, isn't it?
Yeah.
So I've asked if the practice educators can make sure they're linking in.
Yeah, but although they say they're going to honour whoever's on the course now, which means they're going to continue for 3 years, it means that there won't be anybody starting next year in effect. So what do we do with them is the question.
Exactly.
And with the cost of living crisis, it's going to really affect the valleys. Young people wanting to be nursing because they can't afford to go anywhere else.
No, but luckily we have got really good routes through University of South Wales. Most people through the valleys do go through the university, so our pipeline, and like I said, working with other providers, so we've still got a strong pipeline of provision through them and good relationships with them, and it'd be interesting to see how they may react to this news and whether they plan to expand their places, but we don't know the detail yet.
No. Right. David?
Slight change of this topic, but I just wanted I'm not expecting an answer today, but just for maybe next time, whether we can get a note on whether the conversations we've had this morning impact any of the risks on this, particularly in relation to sustainable services.
Well done. Thank you. Okay, 6.9 nurse staffing levels. Jen?
Thank you. So this is the annual statutory report for the board. This report would normally be October to October. That's the period of time for this reporting. We have included an amendment to the autumn calculation made in November, because otherwise it would be 12 months before you have that update. So I will touch on that briefly. I won't talk you through the report because it's very detailed. Clearly, under the Act, we're required to report the twice yearly calculations that are undertaken by myself and my team for the 25B wards. I should say we are now, because of the changes within the Act, We are now undertaking a review of 25A wards, but that doesn't require statutory reporting to the board. So you'll see the results of the spring and the autumn calculations. So there were changes in the spring calculations. So 7 wards in total were identified as requiring amendments. There were 5 in medicine and 2 in surgery. 2 of the medical wards we have since reverted because actually we were putting in something called the core care model. That's a band 4 model, but we were able to recruit registered nurses, so that model wasn't required. We reverted to the original template for those wards. So those are set out within the paper, and those were cost neutral. Within the autumn calculations, which were completed in August and September, there were no alterations required to rosters on the medical wards at that time, and 2 wards in the division of surgery requested an increase in healthcare support worker establishment, but that was funded from a pooled arrangement they had with staff within the Gwent. So again, no additional costs. You will know that Leanne has previously reported to the board the reconfiguration within the respiratory footprint. We have subsequently amended the autumn calculations for those wards. There is a financial impact, however, of 90,665, but when this was presented at Executive Committee, we were assured that that would have a subsequent reduction in variable pay. That reduction will be monitored through Value and Sustainability Board, Variable Pay Group, and obviously Divisional Assurance. So I just ask you to note the changes outlined in the report, receive the assurance we are meeting our statutory requirements, and note that we've received the annual presentation.
Thank you, Jen. Any questions?
Just a comment on it.
Yep.
I just wondered, Jen, whether there's any way we can integrate some of the quality information into this. But we do it every year. Now we're developing the quality data set that we are, whether there would be evidence in there of improvement or there's a problem we need to up staffing to tie it together.
We can definitely add that because obviously there's a quality, as part of the assessment at the staffing levels, there's a quality assessment.
Right.
So we look at key nursing metrics. So yeah, absolutely happy to bring those through next year.
Because it'd be really helpful to know the added value.
Yeah, absolutely.
Yeah. Thank you. We've dealt with the consent agenda. Any other business? No? Thank you very much. The next meeting's the 26th of March.